Good morning. Please take your seats. We're going to get started momentarily. Those of you who don't know, we ring the bell every day just at the start of session. So I thought it was appropriate to do it today. Because we are here and the rest of the building doesn't really get active until around noontime, we're going to leave the doors open. We do not have air conditioning in the house, so we'll leave the doors open. You get some nice cross ventilation. So good morning, everyone, and thank you so much for coming. A few little housekeeping matters before we start. Just so everyone knows, if you need to, there are restrooms to my right, your left, if you need to use them at some break. There's an exit behind you. There's two exits in front of you if anyone needs to step out for whatever reason. This was a wonderful opportunity for all of us to get together and have a discussion about, obviously, healthcare. But before we get started, I really want to give my staff a shout out. They've worked very hard to make this what it is today. And I thank you all for your participation, but certainly my Director of Policy, Lynn Urbani, has been outstanding in organizing it, putting the agenda together. Thank you, Lynn. She doesn't even know we're talking about her. She doesn't even know we're talking about her. So Lynn, thank you. And of course, Nick from Senator Whitehouse staff as well. So thank you, Nick, as well. And thank you, Senator. And what you see here is what we call the pit. And you will notice that there's a lot of people there, and they work every day. But they're all led by an incredibly talented woman who really would be, if I had to give her a title, it'd be COO of the House, and that's Stacey Custer. She keeps all the trains running on time. Thank you. And of course, who's upstairs is my assistant, my everything, Lynn DiPetrillo. Lynn, thank you for all you do. She tells me where to go, what to say, and when to do it. So, Lynn, thank you for that, and thank you for your efforts. So, a couple of reminders. I want this to be a dialogue, an exchange, and I'll ask you to hold your questions until the person who is speaking asks for them. But I want to remind everybody you are on TV. This is live TV. It's being streamed on the Capitol TV station throughout the state. So everything you can say and will say will be used against you in the court of public opinion. So just remember that when you speak, if you're a speaker here or if you ask questions. I really want to thank you all for being here, because this is such a critical issue, and it doesn't happen unless all of us get in the room together. So I'm proud of this fact that so many of you are here today. Some of you were in the gallery above us and behind me, and most importantly, are watching home on TV. My colleagues are here in the General Assembly. There are several representatives here. I'll do my best to recognize them. Representative Barbara Ann Fenton-Fung from Cranston, Representative Jen Boylan from Barrington, Representative Potter from Cranston, Representative Alzate from Pawtucket, Chairman Craven from North Kingstown, Representative Speakman from Warren Bristol, or just Warren, and of course Michelle McGaugh from Portsmouth, Little Compton as well. And I didn't get there. I always swing late. Lauren Carson from Newport as well. There may be one or two others here. I will get to Chairwoman Fogarty, Chairwoman Donovan, and Representative Tansey. Have I missed anyone else? And Representative Art Handy. Okay, good. So thank you. Thank you all very much, and thank you for the opportunity to be here. I will promise to be brief and turn it over. We have an all-star cast of speakers today, and when I look out at this room, what do I see? I see Rhode Island healthcare, the entire system, and it doesn't happen. I want to thank everyone today. I know we all have busy schedules, and I appreciate everybody making time. I want to thank my staff, which I did, who worked very hard, and I want this to be a dialogue, specifically in asking questions, inviting all of you to speak, collaborate at the break, learn from each other, listen to what someone else has to say. We have solved, in the last 3 years, some very significant, complex pieces of legislation. We have passed LIBOR, a reform, after 39 years. We have on the verge of passing a PTSD bill with support from the League of Cities and Towns. With Chairwoman Donovan's help, we passed pay equity after 5 years of it happening, and we crafted that on a weekend, on Father's Day weekend. I won't forget that, Susan. Thank you for your efforts. We have done wage theft and misclassification, issues that have been around this building and this state for 10, 20, 30 years without any movement. And we work together to get things done. And I'm hoping by bringing all of you together, we begin a dialogue to make this all a reality. Like climate change, Senator Whitehouse has been ahead of the curve. He was right all along when he sounded the alarm. The U.S. spends more on health care per person than any other country. We get very little bang for a lot of bucks. Those were statements attributed to Senator Whitehouse in October, and I think that pretty much sums up the problem that we're all in. Sheldon, Senator Whitehouse, my friend, my colleague, thank you. Thank you for what you do, continue to do, not only on climate change, on health care, but being an outstanding public servant. I also want to thank my friend and counterpart in the Rhode Island Senate, Senate President Ruggiero. The Rhode Island Senate has made health care issues a top priority during this legislative session, for which I'm sure you'll hear more about today. Majority Leader Pearson will be speaking on behalf of the Senate later on, and I will let him recognize the senators who are present today. I also want to thank the governor, who has seen health care as a priority and has established a group of department directors and cabinet members to develop a statewide health care plan. Rhode Island has not done that in a number of years, so it's very positive that we're now doing it. Our newest Congressman, Gabe Amo, has certainly hit the ground running, and he will be here later this morning. Our Attorney General, Peter Nerona, will share his perspectives. Expect a lively presentation. Expect him to tell you the facts. As the person who oversees our state's biggest hospital transactions, General Nerona understands the complexities and difficulty and challenges of our healthcare system and what we're facing today. Our healthcare system has been under a great deal of strain for quite some time, and the pandemic pushed it to nearly a breaking point. Healthcare is so important to all of us and to all of Rhode Island. It's personal. It doesn't matter whether you're young, old, or having a pre-existing condition, or completely healthy at the moment. At some point, every single one of us will need our healthcare system. And too many of us have a friend, a relative, a parent, a child who has unmet medical needs because of the tremendous strain of the system we are now presently under. My father is a retired surgeon. He took great pride in his work, and so I understand the medical profession, to me and to the people who practice, is not a job, it's a calling, and I thank you. But doing your job is getting more and more difficult for so many of us, for our doctors, our nurses, our administrators, our behavioral health professionals, our hospitals, and now we're seeing alarming declines in the ranks of the healthcare providers. I've been meeting with doctors this session, nurses, administrators, insurance companies. All have similar issues. So today, I want to bring everyone together to talk about what we can do. We have an esteemed lineup of presentators today who are in the trenches every day. We're going to identify key areas of concern within Rhode Island's healthcare system, hearing from primary care physicians, specialists, administrators. As we know, behavioral health is so important. It's interwoven into all of the health concerns. We'll hear from behavioral health providers. We'll talk about primary care physician shortage and how it's affecting us in Rhode Island, as well as solutions and suggestions on how we can grow a pipeline of primary care physicians. We're doing a deep dive into the current state of hospitals and healthcare delivery in Rhode Island. And we're going to hear from third-party payers and Medicaid. This is an all-hands-on-deck effort. Honestly, I wish we had more money. I wish we could wave a magic wand and fix all of the problems. But since that's not going to happen, Let's roll up our sleeves and get to work. I see Rhode Island's small size as one of its greatest assets. We can get people together quickly in the same room to handle big issues. We can convene a group of some of Rhode Island's leading experts, cutting-edge researchers, specialists, CEOs, and physicians. Our government is engaged at the federal level and at the state level. Today, we have a powerhouse group assembled, and I'm really excited about the feedback, ideas, solutions that will come forth as a result of conversations we have today. The task ahead of us is monumental, but I know that many of the solutions are already in this room. And now, I'm extremely honored to introduce our senator, my friend, Sheldon Whitehouse, who'll be putting forth a reimbursement model he would like our hospitals to review and evaluate. It would potentially create additional reimbursements that we wouldn't otherwise be available to Rhode Island. And we're looking for more ways to make this a reality. Ladies and gentlemen, please welcome Rhode Island's junior senator, Sheldon Whitehouse.
Sorry, I just had to do that. This actually began with my request to Speaker Shekarchi for a meeting with 8 or 10 healthcare leaders to discuss a couple of opportunities that we had coming up. And this is what we got. So it is very much a hallmark of Speaker Shekarchi's leadership to be inclusive and energetic. And so the Shekarchi touch of having moved to this room and this crowd is very welcome, and I'm grateful. I want to thank the Speaker for including me and President Ruggiero for including me. I, as you know, have long worked towards the goal of trying to make Rhode Island's healthcare system a model for healthcare delivery around the country. And I had hoped, as many of you know, that the Lifespan Care New England merger would be the vehicle for moving forward and completing that work, but that was not to be. Even without that vehicle, though, the work can and should go on. And we have two important opportunities before us that I wanted to flag. These opportunities won't last, by the way. There is a window in which they are real, and then they're not around any longer. So we shouldn't waste them. And they're things that we have to do together or not at all. One would be to look to the regulatory system and create a consensus health regulation to protect our Rhode Island-owned hospitals from predation from out of state, and secure improved cooperation between our hospitals. Very hard for them to talk to each other with lawyers looking over. Once you're in the safe harbor of a regulation conversation, you can have that conversation. And I think it's important. I remember when all the major bank headquarters left our state. The economic ecosystem that those bank headquarters supported fell apart as the jobs and the professional support moved to where the new headquarters were. Downtown hollowed out. Downtown Providence still has not recovered. And a lot of civic leadership in Rhode Island was lost. There was a lot of pain, and I don't want to see that replicated with our hospitals. We have to make sure that local control prevails. I don't want to lose the initiative that comes from local control, nor do I want to lose the opportunity for system-wide improvements that are deliverable only through government-enabled cooperation. By regulation, we could set firm terms for out-of-state acquisitions of hospitals and terms for in-state cooperation between and among hospitals. This can form a structure for continuing Rhode Island progress towards a true, value-based, local, efficient, and cooperative healthcare system. Many of us can remember when our big hospital organizations were not getting along with each other. And many of us can remember when they were not getting along well financially. Now we have a window of sunshine while they are getting along with each other and financially, and we should use that window to prepare in the safe harbor of a regulatory environment for stormy days that still may come. So that's one opportunity. The second opportunity is to use the AHEAD program and Rhode Island's application to it to improve our reimbursement levels. I worked very, very hard to undo the imputed rural floor mischief, which for those of you who lived through it knew that it was a dramatic blow to hospital revenues, driven by a very unfortunate decision out of the federal government that we were able to correct. That put Rhode Island on a better payment footing, but it solved only part of the problem. The persistent hole Rhode Island is still in, with lower federal health care payments than neighboring Connecticut and Massachusetts, is a persistent aggravation, an aggravation of decades, and it doesn't lend itself to an easy solution. The AHEAD program moves participants more clearly to full value-based payment, annualized payment. With a little pressure, it could also give us the opportunity to set that value-based reimbursement commensurate with our neighboring states in our regional market, not based on past rates held back by the unfair fee-for-service system, but on regional rates. I know that the delegation will gladly put our shoulders to the wheel to use the AHEAD plan as the vehicle to at last get out of that funding reimbursement hole. And I don't see any other escape vehicle from that fee-for-service hole anywhere on the horizon. This is an opportunity, and I do not want to submit to decades more of unfair Rhode Island payment levels. A health hospital cooperation regulation and an AHEAD reimbursement success will each only come with consensus. I repeat, neither is going to work without consensus. The Rhode Island Foundation has been a particular force for good in this area, as have Integra and Coastal, our high-performing ACOs. Our unions are at the table with expertise and experience to bring to bear. The bad old days of warfare among hospitals and insurers are behind us, and we have leaders in those organizations who well understand the triple aim. If we pull together, there is the chance of achieving a long-sought common good, a major move away from fee-for-service to value-based reimbursement that brings us out of our regional funding hole, and a secure environment for hospitals to secure the cooperative environment that lowers costs through better care. I cannot guarantee that we'll succeed, but this moment of possibility may not last. So let's at least try. Thanks very much. And now, I yield the floor, I believe, to Dr. Howard Schulman and Dr. Hub Brennan, who are making the next presentation. Have I got that right, Lynn? I got that right. Good. All right. Thank you all. We're here for you to try to make those things work. Anything I can do to be helpful, I want to do. Particularly, let's solve the fee-for-service hole through this AHEAD program. We absolutely have to do this. There is not another avenue that I can see. Howard, come on up.
Thank you very much. I'd like to thank I'd like to thank Lynn Urbani in the Speaker Shikarchi's office and the Speaker for inviting me, and all the people here for attending. My name is Dr. Howard Schulman. I've been an adult primary care physician and general internist in Rhode Island since 1995. My remarks will be about 11 minutes. I had my own practice in Warwick for about 13 years, and for the past 10 years, I've been with a 25-physician group called Medical Associates of Rhode Island. My office is in East Providence, and my whole life I've lived whole adult life in Providence. More than anything else, the physicians in primary care feel ignored and powerless with what has happened to our profession. The death of primary care in Rhode Island and nationally is the death of 1,000 cuts, though the wide gulf in reimbursement between medical and surgical subspecialties in primary care is the biggest issue, and nothing will get better until this gets addressed. Actually, determining salaries these days is tricky because between 20 and 30% of what we in primary care make is determined by reporting measures, so-called value-based performance. Additionally, many medical and surgical subspecialties have easy access to opportunities to supplement their income by taking ownership in surgery centers, endoscopy centers, imaging centers, and testing centers, none of which are easily available to primary care. There are also opportunities for collaboration with the medical industry that's really not available to primary care. Within our group of about 25, mostly primary care physicians, our overhead is between 60 and 65%. This cannot go on much longer, and it's only getting worse as we now need to hire staff to manage the reporting issues for so-called value-based performance. Within hospitals, 20 years ago, as primary care physicians stopped seeing their patients when they were admitted, the hospitalists took their place, only seeing hospitalized patients. But because hospitalists were essential for the functioning of the hospital, yet they generated minimal income because they did not do procedures, the hospitals themselves subsidized their income. In preparing for this talk, I looked into this and found out that the salary subsidy is about $150,000 per hospitalist. And the hospitals pay this because the hospitals profit roughly $2 million per hospitalist. The same consideration needs to happen with primary care in Rhode Island outside the hospitals. Strong primary care benefits everybody, patients, specialists, hospital systems, and the payers. Primary care physicians do the initial assessments of patients, counsel patients, advocate for patients, and guide patients and provide backup when the system's shortcomings cause problems, as well as provide continuity of care across healthcare settings and preventative services and oversight. Patients see us first more often than not. I do not know one physician who went into primary care to save the insurance company's money. I do not know one primary care physician who went into this to serve as a source of referrals for hospitals and specialists. Yet this is how we are talked about behind our backs. Typically, the pay for a primary care physician is about 20 to 30% below the Massachusetts level, never mind way below other subspecialties, so trainees don't come here and established doctors are leaving. And we are being replaced by mid-level practitioners. You know, there's a well-known joke among physicians not to get admitted to the hospital in July, because that's when the new resident trainees come in. These trainees have completed 4 years of medical school and then have at least another 3 years of training to practice training till they can practice independently. Yet to become a physician assistant or nurse practitioner, you only need 2 years of school to practice independently. And I guarantee you it is not as intensive as medical school or residency training. And because these practitioners get 85% of physicians' reimbursement, the intellectual, diagnostic, and counseling services, which pay the least, are too often relegated to mid-level practitioners. From your constituents, you may hear people complain that they never get a chance to see their doctor, or they don't even know who their doctor is. I'm not saying that PAs and NPs don't have a role in healthcare. They do, and many are excellent. It's that things have swung too far from paying for experience, judgment, and training. Incidentally, it is hard to see other non-procedural-based specialties like neurology, pulmonary, rheumatology, and endocrinology. I don't like the term physician burnout because it implies there's a problem with a physician. But nevertheless, for lack of a better term, the burnout problem has resulted in a high turnover of physicians, which not only unsettles patients, especially older patients who have a hard time getting used to a new doctor, but also causes expensive disruptions in care. Physician turnover in all subspecialties is a bad thing. Possibly the length of primary care physician-patient relationship could be a quality indicator. Value-based performance, as it is now, is a failure. It has resulted in primary care physicians like myself spending way too much time and attention documenting specific aspects of patient care using poorly designed computer software, usually to the detriment of more important things. Think about what you personally would like in a primary care physician or any physician. You probably want a physician who is available when you have a question or problem. You want someone who will listen to you, take you seriously, and give you intelligent and personalized advice. How about getting a phone call at home? I can't tell you how many times when I do this, I'm told I'm the only doctor that does. These days, many patients value being able to interact with their physicians over the internet. Personality fit and friendliness are important, and not being rushed. Many want someone with a similar background, speaks their language, or who has practiced here for a while and knows the best places to go, the best doctors to see, how things are done locally, and what to expect. Almost none of this is reflected in the current payment system. Never mind writing a good note so the next guy taking care of you knows what happened. The idea of shared savings where the primary care physician or the ACO gets to keep some of the savings for putting extra effort into saving money is a joke. What this really means is that after giving the radiologist a 9% raise, then caving into threats by orthopedics and cardiology and the hospitals for higher reimbursement, their primary care physician gets paid if there's anything left over. Our federal and state politicians, I was going to say physicians, politicians need to get serious about forcing the electronic medical record companies and the hospital systems to let patient information flow from one doctor's office to another, to the urgent care centers, to nursing homes, to the emergency department, to the hospital floor, to out-of-state sites, especially Massachusetts. This is not happening now in many settings, including mine. So because of lack of EMR interoperability, each day, maybe 7 or 8 times, I have to log on to the Lifespan Epic electronic medical records system to get information on my patients. Each time, it takes at least 2 minutes of intensive navigating multiple screens, entering passwords, waiting for programs to load up, and two-factor identification. Each time, the lengthy login procedure in the absence of interoperability needs to get fixed. Even permitting the screen to stay open for more than a couple of minutes before automatically logging off would help reduce this tedious chore of having to log in multiple times each day. Many times I've done extensive outpatient workups on patients, and none of the reasoning behind the testing shows up in the medical record. Frequently when patients arrive in the hospital, they cannot give a history. My records contain this information. There is no excuse for not being able to transfer text or PDF files between computers. No excuse at all. We need a better process to evaluate and rate EMRs, electronic medical records, and then regulate them to improve ease of use and functionality and ensure tech support. The user interface is awful because there's no incentive to improve it because it's next to impossible for the physician group to change EMRs. Ordering labs and x-rays and distributing results could easily occur through a centralized computer system instead of giving the patient a piece of paper each time and relying on faxes and individualized computer interfaces to get results. Currently, I only get electronic reporting of lab results from Lifespan and Eastside Clinical Lab. So when patients have their labs done at Care New England or Quest, my medical assistant has to actually manually enter the results in our computer from a fax. Artificial intelligence is coming. I'm not sure how soon, but it is coming to the doctor's office and the hospital. And if healthcare information is held hostage by the EMR companies, then we will miss a huge opportunity to improve electronic medical records. Furthermore, I am annoyed by the thought that the EMR companies who control patient records will use that information to train AI systems without reimbursing the physicians who generated the data. There's also patient confidentiality concerns. The Department of Health needs to start holding forums to talk with the physicians on the front line and not just administrators. We need more input from the people actually doing healthcare. I'm extremely concerned about private equity and other financial firms buying physician practices, not hospitals, but physician practices doing healthcare. Up until a week ago, I was happy with the ease of doing and getting paid for telehealth. Judging by the pile of notes I get back each day from consultants every day, it is being used appropriately. Furthermore, 2 separate times during hearings for bills in this building, the Blue Cross representative mentioned that his company is happy with the way telehealth is going. However, I oppose the interstate medical licensing compacts for physicians and physicians' assistants because they will ease access for out-of-state, for-profit telemedicine companies to do telemedicine within Rhode Island, which will drain money that should be spent on supporting local physicians and PAs and nurse practitioners. On a national level, there was a 30% and more facility fee that increases the reimbursement for outpatient medical services provided in a facility owned by a hospital. If the payers and the federal government don't level the playing field between independent and hospital-owned outpatient care soon, there will be no competition, and all outpatient care will occur in hospital-owned facilities. I like caring for people from different backgrounds, but due to a federal law, the provider's office has to pay for a translator instead of the insurance company, even though what we pay the translator is often and usually more than what we receive from the insurance level for this visit. Please fix this. The bundle of health care bills going through the Rhode Island House and Senate now do little to address the concerns I've addressed here. There's more. I'll stop here, and I just want to make myself available. I see there's a lot of people here. If anyone wants to, maybe a couple hours, tag along with me in the office, assuming we get the proper clearances, I think it would be extremely helpful for some people to actually maybe spend 2 hours at least with me, if not half a day, and the offenses, to our sense of professional dignity happen all day long, and I think it'd be good to actually experience it yourself. It's hard to just stand up here and talk about it. It's better to actually experience it. Thank you. Sure.
So at this time, while we are fortunate enough to have Senator Whitehouse here, as well as from the provocative comments by Dr. Schulman, it might be a nice time to ask for some questions or comments at all. And I know it's early, but we welcome any and all. Representative Karen, or Chairwoman Karen Alzate.
Good morning.
Morning.
So Representative Karen Alzate, I represent Pawtucket and Central Falls. And so one of the things I thought was really interesting that you brought up is your office or many other doctors' offices, while you do want to be culturally competent and you do have translation services, I guess my question is, do you find it difficult to want to take those patients because your office has to pay for the translation service and the insurance doesn't pay for it? You kind of said it at the end. And so I have concerns about that because so many people in my particular community don't seek out health care for a number of reasons. And then now this is creating another barrier. And so we do have a lot of concerns. And during COVID-19 in the city of Pawtucket, my district was hit the hardest with so many people getting sick and infected and also passing away. So thank you.
Yes, I mean, I think it is a disincentive. I mean, if you're paying a translator $200 for like a $90 visit, I mean, you just don't feel right. I mean, if you're like a lawyer and you're billing per hour, you're willing to talk as long as you want to talk, as long as the client wants to hear you. You try not to pay attention to that, but yes, yeah. You're focused on the patient all the time, and that's the focus.
Thank you, Chairwoman. Lynn?
Senator, we have two healthcare systems in Rhode Island that are for-profit, not-for-profit, but run by out-of-state corporations. How does your plan impact their ability to be in this cooperative relationship, the AHEAD program, when it comes to the reimbursement issue?
You have to be willing to participate in the AHEAD program. The state can join, but then the individual entities make up their own minds. I suspect that that decision may be influenced by our success. If in fact we are able to convince CMS that the rates for the AHEAD program should be set based on regional averages and not based on Rhode Island's history of underpayment and under-reimbursement, then that's an added inducement to participate. But I can't prejudge where that goes. As far as the coordination and cooperation, to me, that's a desire to maintain and protect our existing locally owned hospitals, because I think the day in which no Rhode Island hospital is locally owned any longer will be a very grim day for Rhode Island.
I can't concur more with that statement. For-profit medicine, I think, has been one of the worst things that has happened to this country, let alone the state of Rhode Island.
Hello, I'm Linda Ujifusa, State Senator from District 11, and I'm just wondering if either of you can address the question of whether there is any evidence that value-based payment systems have been working anywhere, because another name for that is capitation, and we have seen that that simply does not work, because what you're doing is putting the burden on providers and patients, when in fact there should be more pressure on the middlemen insurers. So
I just know that it's sort of every month or so our whole group gets together. There's about 25 of us in the group, and most of us are there. And we go over like the new requirement that we'd have to do. And the computer we'd have to have workarounds. And it's every month there's like a new hurdle we have to jump over, a hoop we have to jump through. And most of it, there's a saying, what counts, what counts doesn't count, but what doesn't count, it's hard to like measure actually quality in healthcare, and everything's kind of being dumbed down to a couple of measures like control of blood pressure, the A1C. It's like a number, and it's hard to do that with healthcare. I mean, you're trying to listen to somebody and you're trying to put together a plan as what's the best thing for them, trying to respond to them and use your medical knowledge to help them. And the whole reimbursement system, the value-based care, is not focused on that. It's focused on easily measurable numbers. And I think it's important to get the reimbursement up so that good quality doctors go into medicine. And I guess a lot of them aren't going into like the intellectual, the consultative aspects of medicine. And that's the first thing to do. Thanks.
This is an issue I thought a lot about. I don't have the doctor's experience, but let me offer one thought. First of all, the fee-for-service system we have to get off of that. It just doesn't make sense. It requires enormous amounts of churn. It does not allow the physician to be rewarded for making decisions out of things that are billable. I remember a story of a provider saying, we need to, believe it or not, we need to get this guy an air conditioner and a TV so that he'll stop being a frequent flyer in the emergency room. You can never get reimbursement for that. You've got to have a doctor who's invested in making that work for that patient. And it turns out he was turning up in the emergency room because he was hot and he was lonely. And it actually worked. And the system saved a bundle just for giving a guy an air conditioner and a television. But you can't make an air conditioner a benefit, and you can't make a television a benefit. So getting off of fee-for-service and to value-based care opens up room for that kind of initiative beyond the specific elements that are fee-for-service-able. It also eliminates the incentive that a practice might have to run the meter, just to churn, and drive up billings. And it's in response to that that a lot of stuff has been put in place to try to control for that. Once you're off of fee-for-service, you don't have to control for that any longer. The alignment of the practice and the insurer is pretty good, if not perfect. So one of the things that we're doing in Congress, I have a bill that would say if you're in a value-based system, like if you're an ACO, then nobody can demand prior authorizations of you any longer. If you're an insurer who wants to get a prior authorization, you got to go and get prior authorization from CMS to impose your prior authorization. Because if you're afraid that somebody is churning and the very expensive stuff you need to head off, then prior authorization makes sense. If the practice is economically motivated to be efficient, to provide the best care and the best health at the best price and cost, then there's no incentive for the doctor to be doing any of that. So why would you bother with prior authorizations? I think we can get rid of them in value-based care. And that's only one of many steps in the measures and countermeasures between payers and providers that I think can begin to fall out of the system. We are now in the worst possible situation where everybody still has to run their fee-for-service system in order to keep track, and then they have to run their, for instance, ACO value-based system on top of it. And what I'm hoping that the AHEAD and other programs will begin to do over time is, instead of having a foot in both boats and having to run both systems and integrate and cross-reference them, you'll actually be able to make the move to a system where you don't have to track that any longer, and doctors are far more free to pay attention to patients and not to those double systems that they now have to manage as we move through and into value-based care. Make sense?
If I could just add, the problem is in the details in terms of what is value. And I spent 2 paragraphs going over what you would want in a doctor and probably the healthcare system would want in a doctor, and it's just, you just can't put a number on it in terms of someone that, like a good lawyer, you know it when you see it, but it's kind of hard to like rank them or give them a number. So that's part of the problem.
It's Courtney Nicolato. I'm the president and CEO at the United Way. One of the things that Senator Whitehouse brought up, and I'm curious as to your take, is social determinants of health. It's really driving healthcare needs and healthcare outcomes. And so as a primary care physician, that's an added responsibility, I know, because you are often first line of defense in identifying where those exist. So how does social determinant needs integrate into your practice, and where are there opportunities for really enhancing that?
We do our best. I mean, we fill out, someone wanted a walk-in tub, and I had to fill out a whole big form so that the insurance company could pay for it. And we do our best. Sometimes we counsel a patient on what's important. It's sort of a big topic. We do our best. I mean, we advocate for the patients, and whatever we can do sort of within the scope of our practice, we can do. But more often than not, we give people extra attention, counsel them, and a lot of it's somewhat out of our hands, but we're patient advocates first and foremost.
That's important as part of this conversation is we can't separate social determinants and medical outcomes, right? They are part and parcel. Often, I know that healthcare professionals are trying their best, but I think if we're really talking about the healthcare system, I think social determinants need to be part of that system. So that's the question, because it is complicated. And there's lots of great organizations doing good things, but to be able to provide support, but I think we can do a better job as a state.
Right, well, while they're in the office, we do our best, whatever they need.
Yep, yeah. Thank you.
Thanks.
Morning, Dr. Shulman and everyone in the room, and Senator Whitehouse. I'm Denise Coppa, and I represent the Nurse Practitioner Alliance of Rhode Island. I also run the nurse practitioner program at the University of Rhode Island, and I have a practice at Hasbro for the past 35 years. I take issue with the fact that the narrative has been about physicians in primary care when there are 355,000 nurse practitioners in this country, 80% of whom are in primary care. Since 2010, with the Affordable Care Act, when that was passed, the whole perspective of primary health care has shifted to team-based health care, where people work collaboratively in teams. So I really would like the narrative to be expanded a little bit so that people start including nurse practitioners in the discussion on changing primary care to increase access to care. We're no longer mid-levels. If we're considered mid-levels, then I look around with my colleagues and I say, well, who are the low levels? Who are the low levels in primary health care? You know, who are we working with in teams that are not considered to be good enough to be mid-levels? Our education is based on at least 4 years of college as nurses, and then another 2 to 3 years in clinically based primary care programs. So I'd just like to help you expand your perspective on primary care. Thank you.
Thank you. I think it's, I sort of anticipated I'd get feedback like that. And I think it's a level of degree. And it's not sort of a black and white issue. I think probably towards the beginning, when someone comes just out of school, they're probably at a disadvantage. But I think probably after a while, probably after 4 or 5 years, probably the PAs are probably just as good as most of the physicians taking care of people. I think very often the physicians are the ones sort of, when the problems happen, they're the ones ending up having to come up with a solution. But I think, especially in the beginning, there's probably more of a difference the first couple of years in practice.
One more comment, and that is that nurse practitioners, when the program started in the mid-60s, it was because nurse practitioners went to areas that physicians did not want to go, to rural areas, to inner city areas, to home-based primary care. And that still exists. So there has to be a broader perspective on who is serving the primary care population in the country.
Yeah, it's also just not with primary care. A lot of times the specialists, of course, they're seeing PAs and the specialists. I think more PAs are going to work with specialists. They earn more, sometimes more than us, you know, working for the specialists. And a lot of times I'll have someone see a specialist, and I kind of wanted them to see the doctor who has experience in that. And I'm just being frank. I mean, you know, I would have wanted them to see the doctor at that time. As the primary care physician who's looking out for the patient, it's okay, but it's a matter of degree.
Thank you.
Thanks.
Thanks, doctor, for your insights. Sorry. Quick question on demographics. So 2 parts. One, at one time when we did studies, it wasn't all the number of primary care, it was distribution across the state along some of the lines that were just mentioned. Are they in the right neighborhoods? Are they in the right rural areas? I don't know if that's still an issue. And the other part on the demographics that we don't seem to hear as much about is aging, both the aging out of the doctor population and the rapid aging of our Rhode Island population that may require more healthcare services. How do those two fit in to, again, the look at how do we supply healthcare?
Right. I think a lot of doctors, as they get to be age 60, 65, could easily practice another 5 until 70, 72. And a lot of doctors are at 65, they're saying, like, I'm done. You know, if they don't enjoy what they're doing, if it's too monotonous, if it's too much stress, and they're not getting enough reward, and also in all manners of the word, they just retire. As opposed to if they enjoy doing what they're doing, they could easily provide another 5 years of health care, very effective, because they'd have patients that are familiar with them, they know the system, they're sort of all plugged in. And I think that's a population you'd want to try to preserve, so that doctors, you don't want people practicing too long as well, but I think it's important to keep doctors practicing as long as they're, you know, capable of providing good care. And I think the older doctors, there's a lot of advantages to them as well, since they're familiar with the system.
Thank you.
Thanks.
Hi there. I'm Deb Hurwitz. I'm with the Care Transformation Collaborative of Rhode Island. And thank you to the speaker, the senator, and Dr. Schulman for your comments. I want to just offer to the group that the Care Transformation Collaborative Task Force released a report in January that studied this issue. of primary care access and released a report with 6 primary goals and action steps that can be taken over time. They're not all legislative, but action steps that can be taken to sort of right the ship. We're in a really tough time right now with primary care, and it's extremely fragile. I've been doing this work as the executive director for CTC for over 14 years, and I've never seen primary care as fragile as it is now. We have people retiring. We have, as you mentioned, all of the different factors that are, buying up practices, people are leaving. We have a number of issues that are affecting the ability for us to have access to primary care. Now, some of those are that we only have one medical school, Brown. We don't have a state medical school. We don't have a pipeline of primary care providers getting ready to take the place of those who are retiring. We I think it was in 2023, Brown graduated 106 students, and 30% of them went into primary care, and only 15 stayed in the state. So that's not a pipeline. And then we've got nurse practitioners and PAs that are being trained, and when I asked them, can you train more? They said, no, we don't have enough clinical training sites. So there's a whole sort of array of different things that are impacting our situation. Payment, as you mentioned, is a big one because students coming out of school with $300,000 worth of debt look at, what do I want to choose? Is it a specialty? Is it primary care? Is it at the bottom of the barrel? So they pick a specialty so they can pay off their loans. So that problem's been happening for a while. That's not a new problem, but it was really accentuated during COVID.
If I could just comment on that. Our practice has been around for like 50 or 60 years, and most of the doctors from our practice used to graduate from Rhode Island Hospital, used to be in the training program. The past 10 years, nothing. We have a pipeline. It's just going somewhere else.
It's going somewhere else,
Yeah,
right?
so
exactly.
they're not coming here.
So we really need to look at this broadly, payment being an important piece, but also as a state, we have to shore up our training capacity, and the clinical training sites need to be compensated and funded in a way that they can really provide the preceptors that the trainees need. So I offer that report as something that folks could reference, and happy to talk to anybody about it. And I want to also thank the co-chairs of that, Dr. Jeff Borkin, who I don't think is here today, and Denise Coppa, who just spoke before me. So thank you.
Thanks.
Okay, I think, Dr. Schulman, thank you very much. Thank you for the questions. At this time, we'd like to introduce and bring up Dr. Hub Brennan from East Greenwich, Rhode Island, practicing primary care physician. And then we'll take a break.
Thank you very much, Lynn. Thank you for your introduction. I had said to Dr. Schulman during breakfast that if we hang around long enough and we lose enough hair, that people will begin to think we know what we're talking about. And I think, Howard, this morning we've proved that to be correct. Howard's been a good colleague. We started practicing just about the same time, some 30 years ago. He's been a great colleague over the decades. Senator Whitehouse, Speaker Shikachi, Attorney General Nerona, and of course, Ms. Urbani, for your kind invitation. Bit of an introduction. I'd like you to know who you're hearing from. My name is Hub Brennan. I'm a Rhode Islander, born and raised in East Greenwich, practice in East Greenwich, and have for just now approaching 30 years. My undergraduate education was at Providence College, thereafter Midwestern University in Chicago, which was then known as the Chicago College of Osteopathic Medicine. I completed my internship, residency, and chief residency at a wonderful place called Pawtucket Memorial Hospital in Pawtucket. Yeah. And in fact, had the distinct privilege of working alongside the speaker's dad. He was still in practice at the time, and such a true gentleman he was and is, and it proves that if you plant beans, you get beans, like father, like son. I've always remained civically involved, if you will. I've served on a variety of boards and commissions locally, nationally, and internationally. I'm the former chair of the state's Judicial Nominating Commission. first non-attorney to do so, and certainly the first physician to do so, something that we should be proud of, Howard. I also serve as a member of the advisory council to the Office of the Health Insurance Commissioner and the Commissioner himself. I've done so since the office was stood up under the Kucheri administration, then under Chris Kohler, and currently under Commissioner Corey King. I'm president of the Kent County Medical Society, and I'm a former president of the Kent Hospital Medical Staff and trustee of the Care New England Board. And obviously been asked to speak here today on the issue of primary care as a key area of concern for us as a state. First, if you will, some general comments regarding the general condition of Rhode Island's healthcare environment, as the elements upon which primary care doctors rely are inextricably interdependent upon this. The spoiler is, I will conclude in the end, that what we have is anything but a system. We are more a disparate collection of industries or compartments, if you will, banging into each other as we struggle to fulfill our individual missions, yet with an undisputed common goal, and that's the health and well-being of Rhode Islanders. We are all silos on the same farm. One of the main themes you're all hearing from our doctors, dentists, and other colleagues is coined regional parity. We all know by now that means the disparity in reimbursement for services, pay for doctors and hospitals between Rhode Island and our contiguous neighbors, Massachusetts and Connecticut. 30% has always been the best estimate. We also know that there are many factors that contribute to that disparity. That disparity is a problem for a lot of reasons, and you'll hear a lot about that this morning from people a lot smarter than I am. And there are excellent points to be made from all sides of the debate. If this were easy, we would be elsewhere this morning. I chuckled and laughed. We testified before the House Health and Human Services Committee some 2 or 3 weeks ago, and I sat next to my very dear friend and close colleague, Laurie White from the Greater Providence Chamber of Commerce, and we were on completely different sides of this issue. Her points, however, were all very well taken. And that moment was, again, a good reminder and a reminder for us all. Let's always separate people from issues. These are all good people with very good points. Why is it such a problem for doctors and hospitals? Well, to start with, it certainly doesn't seem fair, does it? You take a hardworking primary care physician with patients to see, emergencies, on-call, phone calls, staffs to support, hospital duties, electronic health records, the administrative burden of prior authorization requirements, and put in their heads that they're doing so at a 30% financial disadvantage. And what you've got then is a big bunch of professional victims. They're disgruntled before they get to the office to see their first patient. The doctors we have feel this way. And until they quit, move, or retire, once they do, our problem compounds. Just who's going to replace them? We've had the discussion of advanced practice professionals, PAs and NPs filling the void, and that may be where this goes. It's happening as we speak. So allow me to dive into a few specifics of the topic about which I was invited to speak. Now, I'd like to stand here and tell you that I'm above the market, that I'm not a player in this discussion, but I am. I'm still practicing. I've got 30 years behind me. I hope to have several years of practice ahead of me if my health holds out. So no, I'm still in the market, but please, many of my productive years are behind me and not ahead of me, trust me. So for over 30 years of practice, from the tail end of fee-for-service, submit a bill to the insurer, get paid that amount from the payer. That was our forebears' arrangement. On to discounted fee-for-service. In exchange for volume enrollment with a payer, never mind what you're charging, here's your reimbursement per visit, the fee-for-service that the Senator speaks to. On to risk contracting. Risk contracting first with limited downside. This was something we entered into through our provider network, the Rhode Island Primary Care Physicians Corporation. In fact, I know our CEO, Noah Benedict, is here today. And we learned via failure and then success. roughly 150 members in the provider group, and it's been through trial and error and a robust IT support system that success at limited downside at-risk contracting has been realized. That group now looks forward toward greater success through direct full risk contracting and the adoption of AI technology. So in my career, 30 years, started no cell phones, no electronic health record, working in the same building as Dr. Shikachi, now to the advent of, through the EHR and now to the advent of artificial intelligence. It's certainly been quite a ride. I'm an independent doctor operating a small business. There are 5 physicians in my practice in East Greenwich. Again, all independent operators under one roof. I see about 14 patients per day. I book 30 or 40 minutes per patient, regardless of the complaint, whether it takes much less than that or much longer than that. With the patients of my patients, it all seems to work out. I take overnight call for 6 doctors who are responsible for about north of 10,000 patients. I'm on call every 6th night and every 6th weekend. I still follow my hospitalized patients. Regrettably, I'm the only doctor left at Kent Hospital who does so, and I do plan to practice for several more years. So basically, I'm introducing myself as a dinosaur. But my absolute love of my patients and my profession is challenged by but a very few things. And they're no different than those that affect many of my colleagues you've heard and will hear later throughout the day, privately, publicly, and as a matter of public record. Administrative burden. This is not the business aspects of running a private practice or a business. My partners and I actually enjoy that, the hiring, firing, supporting, growing, nurturing of our staff. This means anything that stands between my patient and me during the evaluation, contemplation, consideration of diagnoses, testing, and their treatments. That, to us, is administrative burden. Access to services and specialists. My colleague had mentioned this earlier. Lack of specialist access is prolonging urgent testing and referrals that clearly place patients at risk. For example, symptomatic cardiac patients, that is patients with some chest symptoms, chest pressure, abnormal EKG tracings, are scheduled out weeks for tests, which are stress tests or nuclear stress tests, are scheduled out weeks for tests that by right should be completed within a day or two, actually should be completed within hours. Prior authorization requirement for services I have ordered is the biggest frustration for my partners and myself. I'm going to use an anecdote, and the payers always cringe when I suggest I'm going to use an anecdote, but I do think it's important for you all to know what Dr. Schulman and I do every day in and out as it relates to these issues, kind of a boots on the ground, real-life anecdote, if you will. So 3 weeks ago, my 55-year-old female patient with a history of multiple sclerosis developed severe, disabling low back pain radiating into her left leg. She failed conservative treatment, and her findings were very suspicious of a herniated lumbar disc. She failed short-term narcotic pain medication. I ordered an MRI of the lumbar spine. It was denied by the insurer after it was ordered. After 10 days. Actually, it was denied by the vendor that they use to make such determinations. I promptly referred her to a neurosurgeon who saw her immediately in hopes that his order for the MRI would be approved. While awaiting this approval, and he agreed that the test was indicated, the patient deteriorated, fell to the floor in her bathroom one morning in severe pain and weakness, and was transported to the hospital. There she received 2 MRIs, one in the emergency department during workup, and then once admitted, the neurologist needed an additional MRI with better focus on the area in question. She was seen by the neurologist, diagnosed with a severe herniation of the L5-S1 disc on the left. She spent several days in the hospital. This is simply unacceptable patient care brought about by the prior authorization process. If that test was completed as ordered, the cost savings would have been, the cost would have been but a fraction of the costs that were ultimately occurred to the patient and to the system. Tenfold, 100fold, I don't know. This is but one recent example, but please know this happens all the time. There isn't a week that goes by that my partners or I don't run into something similar. As we practice today, doctors are simply viewed as overutilizers by the health plans, and the plans are viewed as simply obstructing proper patient care. Nothing about this portrays a system of care. As has been mentioned, recruitment and retention. National data supports Rhode Island's market position for best or worst places to practice, and it's embarrassing. It also has also remained largely unchanged for quite some time now. While my practice has had some limited success in recruiting new doctors, much owed to our participation with the Kent Brown University residency program in internal medicine, we are an outlier in this regard, as you'll hear from my colleagues throughout the day. Availability equals access, and access is a problem. So we should dispense with the notion for correcting for any doctor shortage with additional doctors. We will have all we can do to replace those lost through attrition, as Howard had mentioned, and we are failing. We're falling behind. Next, reimbursement. Now, how can I, as a physician with a very comfortable income, stand before you and advocate for higher physician reimbursement? As the speaker has said to me and appropriately reminds us, we will find little sympathy among the vast majority of Rhode Islanders for doctors complaining about their wage. And he's right. Fancy cars, lifestyle, so forth. Now, I will say my Jeep has 70,000 miles on it, but you want to see my dump truck. I stand here because I have but a few years ahead of me my practice, and this is far more impactful on my younger colleagues, which at my age is most of them. I have always cared for my patients first, tried to be very efficient with my business, and lived comfortably on the prevailing wage. Yet what has been good enough for me will not be ample for the future doctors of Rhode Island and for Rhode Islanders. In fact, they won't come, at least not in ample number to support our needs as a population. The physician reimbursement issue is a physician access issue. We will be wise to recognize and address this. Doctors and their patients need hospitals, and vice versa. The struggles of our hospitals are well documented. The hospital leaders I speak with tell me they worry more about money and how to keep their institutions afloat than anything else. Razor-thin margins, if a margin at all, year-over-year losses, age of plant stretching beyond cost of maintenance and repair, robust capital budgets, a thing of the past, loss of high-value surgeries and procedures, particularly orthopedic surgeries, to physician and investor-owned state-of-the-art ambulatory surgical centers represent the present and the future. And by the way, those surgeries are not coming back. These entities are out there thriving, doing a very good job, and really satisfying the patients they serve. Hospitals are having to divert local rescue trucks away from their emergency rooms due to a lack of beds, read lack of nursing. This starts a shell game as to who's open and who's closed to rescues. Rescue vehicles crisscross the state, making them unavailable to the cities and towns they serve. Patients lose contact with their established primary care physicians and specialists in the process. Continuity of care suffers as competing systems try to capture the follow-up care of these patients after discharge. Hospital-employed doctors and specialists are heading for the border as well. Just like primary care physicians, they have the same recruitment obstacle, regional pay differential. There's a joke inside of medicine that the only 3 reasons one would practice in Rhode Island is our love of Dell's lemonade, our love of coffee milk, or that we're simply stupid. So I stress to you and I stress to my patients, I love Dell's and I love coffee milk. Our hospital system leaders, and I will add the current class are exemplary in my opinion, are experienced, devoted, and skilled professionals with immense responsibility, both as employers and standard bearers of care. Even between them, there are differences in philosophy as to how the problem, direction, and ultimate solutions to our state's healthcare condition can be achieved. In one ear, we hear the wisdom of a need for a far more robust economy, Rhode Island, and economic development in Rhode Island. That would benefit all healthcare boats and all of healthcare, and the rising tide would lift all healthcare boats. It's a concept none here would disagree with, yet it's decades down the road. In the other ear, we're enlightened to the benefits of population health, true population health, as the key to caring for people as a whole, with an efficiency that begets controlled costs, and then quality and best outcomes. And even another voice of clear pragmatism and urgency, reminding us, all well and good, but we don't have time to consider the ethereal. Rome is in fact burning, and even if we were to act now, the effect of such actions are years out. I must applaud Aaron Robinson and the South County Health family for their leadership on these issues. We likely would be elsewhere this morning if not for their thorny persistence here. I'm beginning to think of them as Rhode Island's little engine that could. There's an esprit de corps down there that should really be a lesson to us all. All good, brilliant people with brilliant ideas, pointing out the fact that our hospital systems are not remotely on the same page on these issues. And this is not helpful, as it can only serve to frustrate the work ahead and frustrate the legislators, you legislators, who we now turn to for help. Our insurers, in their missions to fulfill, have their missions to fulfill as well. Raising premiums on individual employers to keep pace with near exponential rise in fee-for-service care was never going to work. Enter the managed care organization, rendering traditional indemnity insurer as a quaint remembrance of the past. Insurers began overseeing care, read the cost of care, monitoring, reviewing, and requiring approval before care can be rendered by a physician. Insurers and pharmacies are entering the retail healthcare delivery space, even competing directly with doctors and hospitals, using their services or enrolled with their plans. All in an admirable effort to preserve a margin and to succeed. The regulator, the Office of the Health Insurance Commissioner, and again, my history there goes back some 20 years there. I've been proud to sit on that advisory council and sit next to geniuses like Al Charbonneau, who I think is here. I can assure you I have learned far more over 20 years than I've ever contributed to your committee, Commissioner, and it's been a privilege to do so. Our current health insurance commissioner, Corey King, who is brilliant, by the way, and each commissioner before him have steadfastly executed their charge to protect the interests of consumers, the solvency of our plans, protecting the interest of providers, and improving Rhode Island's healthcare system. This is a data-driven agency expert in separating facts from all else, the hyperbole. Downward bending that cost curve for purchasers of insurance is and has been its primary objective. The office over the decades has done so with some success and notoriety. It's heads down work. It's my belief that the work is done absent of politics, as well it should be, and with the assumption that all of the elements under its purview are functioning, alive, and well financially. But when the heads are lifted, we now find that we have an uncalculated variable, a flawed premise. We have a lack of access. It's my understanding that legislative work and agency action would expand the charge of OHIC to consider such a critical variable and encourage and support those efforts. Honorable mentions go to those who oppose the regional parity. Again, my friend Ms. White with the Greater Providence Chamber of Commerce has dutifully and expertly voiced the concerns of the employer community over the financial impact of whole-scale parity upon her constituents, and that's duly noted. My colleague, Commissioner King, makes a compelling argument that it's too big a hammer and prefers addressing the issues by moving the levers at his grasp, and I admire him for his work. So thank you all coming to the table, for your voice, being part of all of this, in helping us care for each other. So just some closing thoughts, if I might, some simple things. It's become clear, I think, to all of us that there's no room in healthcare for profiteering. Look in-state or to our immediate north for ample evidence. Attorney General Noronha, thank you for being our watchdog and guardian in this regard. Today we are hearing largely from those poised to earn more, to collect more revenue, that there is a clear and present danger before us. There's a group of people more important than us, however, and these are our patients, our fellow Rhode Islanders, and the businesses that employ them and insure them. They are the payers in this equation. Any additional expense is going to need to make sense, not to us, but to them. There's a point going forward that this expense, however, will be recognized as an investment. That point is when a person in need cannot find the care they deserve. We in healthcare suggest the problem is now. Others suggest that the problem lies in the future. But let's all leave here agreeing that we have a problem to solve together, and please, let's do so before it's too late. Thank you all again.
Thank you so much, Herb. We appreciate it very much. I think at this time, I'd like to just acknowledge, though, Representative Gabe Amo has joined us. Congressman Amo, thank you for being here. And I think at this time, unless there's an urgent question, we'll take a 10-minute bio break. You can exit through these two doors. There's a little bit of refreshments, and we'll be back in 10 minutes to hear from our hospital leadership, as well as behavioral health and the dental community. Thank you. Lineup for you this morning. So if I could ask everyone, try and head toward your seat. We have more of our wonderful speakers who will be presenting. Next, just to keep things moving along, I'd like to introduce President and CEO of Butler Hospital and the Providence Center. We all know how important behavioral health is, in addition to primary care, and many of the subsequent presenters today will be sharing their perspectives. But Mary Marin, please, from Providence Center and Butler Hospital.
Okay, my first tip was to make sure everybody could hear me. I understand there's been a little difficulty in the back of the room. So with that, I would like to thank you for inviting me to this important forum and for recognizing the importance of behavioral health in the context of the Rhode Island healthcare system. Good. Thank you, Speaker Shekarchi, Senate President Ruggiero, and Senator Whitehouse for including me today. And thank you to Lynn Urbani, I think, for asking me to talk today. We'll see how this goes. Thank you for your continued support of behavioral health in your efforts to meet the healthcare challenges we currently face here in Rhode Island. I would also like to acknowledge EOHHS Secretary Richard Serest, who I believe is not here today. I think he's feeling under the weather. And our new BHDDH Director, Rich LeClaire, and their teams, because they have been doing some really hard work on behalf of behavioral health, and I'll talk a little bit about that this morning. For those of you who may not know me, I'm Mary Marin. I am the president of both Butler Hospital and the Providence Center. I also serve as Chief Administrative Officer at Care New England, overseeing the behavioral health service line. And in terms of complete disclosure, I am the board chair of the Hospital Association of Rhode Island. With that, I kid you not, I do know how to juggle, but I couldn't do all of this without the great work of the teams that help and support me in my various roles. A comprehensive continuum of behavioral health is essential to a strong Rhode Island healthcare delivery system. The well-being of all Rhode Islanders improves as we invest in a continuum of care that brings timely access to cost-effective behavioral health services. We're all well aware of that the pandemic has resulted in unprecedented demand for behavioral health services. It's overwhelmed our emergency rooms and, quite frankly, is challenging our capacity in the community. In some ways, the silver lining to the pandemic has been that more people are talking about behavioral health and are acknowledging struggles with depression, anxiety, substance use disorders. However, the problem that presents in front of us is adequate capacity to timely services. I want to make it clear that these challenges have not gone unnoticed by you, our state legislative leaders, and our federal delegation. With that, I want to express my sincere gratitude for your efforts, because there's been many. I want to highlight a few of these recent efforts here, and I want to start with, and I hate to bring us back to the pandemic, but I want to start with the work we did together to open a low acuity short stay unit on the campus of Butler Hospital. This was about 20 beds. It was really aimed at decompressing the demand on our emergency rooms across the state in the height of the pandemic, when the virus was still about and the demand for behavioral health services was increasing. So with the quick support of Governor McKee and the deployment of the National Guard and the quick work of the Department of Health in licensing my auditorium for a behavioral health unit, we were able to respond to this overflow of patients. Emerging from this temporary solution is the soon-to-be-opened 25-bed short-stay unit at Butler Hospital, aimed at alleviating boarding in the same manner that we tried to address it in the height of the pandemic. Thanks again to Speaker Sicarci, President Ruggiero, Governor McKee, and Senators Whitehouse and Rhode for securing the needed funds for this project. This project is completely publicly funded. We should notice soon, because this unit is opening in the beginning of July, perfect timing with the goal to end ED diversion at our hospitals. This unit should make a significant difference in the number of folks boarding in our emergency rooms. Also of note is the enhancement of our children's emergency services and mobile treatment services. We have seen a benefit in terms of lower inpatient bed utilization and reduced boarding of children in EDs. I want to note, I think I saw Henry Sachs in the audience in Hasbro Hospital, who took a real lead along with the OHHS in terms of pediatric bed capacity, and these services are making a real difference. Workforce stabilization dollars also have been of great benefit in the community. We've seen ARPA funds being directed to our community mental health centers and providers in an effort to retain and recruit staff to this critical work. This also is helping prepare us for the CCBHC initiative, which is underway. Although a bumpy ride, and I would say that we are building the plane as we are flying it, maybe, or almost about to fly it, I do want to thank EOHHS and Buddha for being thoughtful to the impact on providers as we prepare for this very important initiative. CCBHCs should reduce the need for inpatient hospitalization. They should allow individuals who struggle with serious and persistent mental illness and substance use disorders to remain in their communities of choice and avoid unnecessary inpatient stays or ED visits, quite frankly. We have also seen continued efforts on the opioid epidemic front, bringing us programs over the years like Safe Stations. We are now about to open our first Compassion Center. This, along with enhanced substance use disorder services that will be made available by our CCBHC efforts, should have a significant impact on both opioid use disorders and alcohol use disorders. I do want to once again thank Senator Whitehouse and all of you for the work you have done doubling down on the opioid crisis. It's very important. We did lose some ground with the pandemic. It's very important that we stay vigilant there. Under Secretary Charest's leadership, efforts are underway to improve conditions and access to longer-term hospitalization at Eleanor Slater. The outpatient clinic, I don't know if folks are aware of the outpatient clinic at Eleanor Slater, is working hard to transition appropriate patients to the community, including some long-term forensic patients who are safe and stable and can be in our community. Butler Hospital has been partnering to be a bit of a backstop for that period of transition, in that it's not unusual that one might need stabilization, a quick hospitalization in the course of that transition, so we're trying to be helpful there. In addition to these efforts, I'd like to note the importance of provider-payer collaboration in delivering evidence-based care to those covered by commercial insurance and our managed Medicaid products. Martha, as you know, Blue Cross and Butler have collaborated now for several years in providing assertive community treatment to the commercially insured via the Health Path program. More recently, we have been working on transitional outpatient services that are really aimed at successfully stepping folks down from higher levels of service by providing case management services. Blue Cross was the first payer that actually has reimbursed case management at the hospital in our ambulatory areas. This same program allows us to safely divert folks who present at our ED, in that we can bridge services, provide medication management and case management until we get the individual to the right level of care. A very important body of work that we've been doing over recent years. Other insurers are now looking and interested in these services. United Healthcare is working with providers to enhance ED peer recovery services for individuals struggling with both opioid use disorders and alcohol use disorders. This is aimed at connecting one who presents to the ED with a peer and helping them successfully connect with next point of care and hopefully successfully enter recovery. And lastly, we've done some work with Optum over recent years around medication adherence for our community mental health clients. My overview is by no means exhaustive, but it just gives you some example of a lot of really good work that is currently going on in behavioral health. So thanks to everybody who is playing a role there. So what remains? The momentum is good, but there is still work to be done. Continued investment in integrated behavioral health services in primary care is needed. We're talking a lot about population health and value-based care, and integrating behavioral health services into primary care is essential to our success in that space. We should think about behavioral health care as primary care to support early treatment of emerging behavioral health conditions. The sooner we diagnose and treat mental illness and addiction, the less disruptive these disorders will be to those who are afflicted by them, and the less money we will spend in treating these conditions down the road. Emergency and inpatient psychiatric care should be the last line, not the first line of defense. I know, I do run an inpatient hospital. You're probably wondering, okay, how's she gonna make that work? But I'm ready. It's also essential to stay on track with the transformation at Eleanor Slater Hospital to ensure appropriate placement of patients through civil admissions for longer-term hospitalization. Longer-term stabilization of the severely ill remains a needed component of our continuum. You should not have to commit a crime to get into long-term care. We continue to board patients who are not appropriate for acute hospitalization in our hospitals across the state. I know you are aware of the situation just brought to light relating to adolescents stuck in psychiatric inpatient facilities due to lack of appropriate community-based residential beds. For many of these kids currently left without appropriate placement, this is the beginning of a lifelong challenge. They will become the adults that are caught in our acute care hospitals, sometimes for years. These adults also await appropriate community-based residential care. We are in need of more intermediate care facilities here in Rhode Island for both children and adults. By investing in community-based residential care now, we will not only improve the quality of life for these individuals, but also create a more efficient and stable healthcare system for all of Rhode Island. We also need to consider how to more effectively care for individuals with intellectual and developmental disabilities who suffer from behavioral health conditions. These conditions can result in severe behavioral problems, which include violent and aggressive behavior. These individuals present a challenge when they cannot be safely managed in our community. Specialized acute and intermediate care options are needed here to address this unique challenge. These are among the individuals who are spending days in our ED, and I need to add that my short stay unit won't help this problem. I also want to say that the conditions of the facilities that we care for those made most vulnerable by mental health and addiction matter. The physical state of our community-based and residential settings speak to the value and respect we place on individuals suffering from severe and persistent conditions. The facility improvements now underway at Eleanor Slater campuses are long overdue and welcome. But we need similar attention to our community settings. I know there is a renewed effort here on the part of our state agencies. This is important work and needs to continue, if not accelerate. I want to respectfully note that the cost of these improvements and ongoing maintenance of these state-owned properties cannot fall on our providers without concurrent improvements in the rates we are paid for these services, which many of these services are both our group home services and other residential programs. So you may be saying, why has she not talked about the workforce yet? Well, here it is. First, I want to say how privileged we are here in Rhode Island to have so many passionate, dedicated people caring for those who are struggling with mental illness and substance use disorders. We need to continue all of our workforce development efforts, but the safety and well-being of our workforce hinges on a continuum that provides the right care at the right time and place with a sufficient number of well-trained staff. Patients who live in environments or who stay in, and this is important when we talk about the safety of our staff, patients who live in settings that exceed their capacity to manage the setting, this will worsen their symptoms and their presentation. And many of the folks that I'm talking about in terms of those that need higher level community-based patient settings, many of these patients, the result is violence and aggression. It's more than they can manage. An appropriate specialized environment uniquely designed to meet their needs, particularly the IDD population, is necessary and will better protect our staff in the behavioral health realm. So, the good news is that much effort is underway and the spirit of collaboration is at an all-time high. That's because of the collaborations that happen with people within this room. You, our government leaders, our providers, our payers. You are the ones that need to come together to continue this great work, and I hope that my representation of what's already happening gives you a good sense of progress underway. I'm eager to see us build on this momentum and continue all of these important investments. It's important to continue all of these important investments in the coming years. We have bridges, we have other needs, but this one needs to stay on the front burner. We can be, when I first came to Rhode Island, believe it or not, in the mid-'80s as an occupational therapy student, 40 years here in Rhode Island, I came because this healthcare system the mental health system, the community mental health system, was a leader in the nation. We're doing better, but we can return to that status. And I'm confident, because it is Rhode Island, because we are small, because we can all come together in a room like this today, we can make that happen. Thank you again for all of your efforts, and thank you for the opportunity to speak this morning.
Thank you so much, Mary. At this time, we'd like to hear from our dental and oral maxillofacial team. So Dr. Frank Paletta, who is the president of the Association of Oral Maxillofacial Surgeons. Thank you, Dr.
All right. Thank you, Len. Hope everyone can hear me. Thank you to Speaker Sicarci and Senate President Ruggiero and Senator Whitehouse for hosting this event. I'm just going to read off some notes that I had, and as I sat here earlier and listened to the two primary care physicians speak, Dr. Schulman and Dr. Brennan, I looked at my notes and I said, boy, did these guys steal my notes? Because there's a lot of similarities in some of the issues that we're having from a dental standpoint. So my talk here is not meant to really criticize anybody, but sort of present some facts, and some of them being personal in terms of what's going on here in Rhode Island, and hopefully find some solutions to improve health care for all the citizens in Rhode Island. So let me give you a brief overview of what I do and what an oral maxillofacial surgeon is. So I do have practices, one in Rhode Island, and I actually have one in Massachusetts. And we'll get into it later why I have a office in Massachusetts. But a oral maxillofacial surgeon is somebody that would go to college and then go to dental school, which is a 4-year program. And then after that, there is a residency involved. And that residency could be anywhere between 4 and 6 years. Mine was 6 years in length. I also happen to be a licensed physician in the state, so I went to dental school, then I went to medical school. And as you see, there's a lot of education and training, and the cost of education nowadays is skyrocketing. If you have someone that goes to a very good undergraduate program, as most of these bright individuals do, they can incur about $300,000 worth of debt. Dental school, you know, we don't have any dental schools here, so we talked a little bit about training issues, and there's only Brown Medical School. I do serve on faculty at Brown Medical School, and I educate some of the medical students, but we don't have a dental school here in Rhode Island. So the cost of dental school in Boston is about $110,000 a year. And some of these individuals that go on to specialize, whether they be pediatric dentistry, orthodontics, and whatever, there's also an additional cost to them as residents. So we frequently will have dentists and dental specialists that come out $500,000 to $1 million in debt before they even start first day of practice to earn an income to pay back those loans. So when I was first recruited to come here in Rhode Island, I don't have ties in Rhode Island. I'm actually from Pittsburgh. I did my training in Connecticut, and then I went to Mississippi for a year to do fellowship. So if there's possibly one state that may be worse than Rhode Island, it could be Mississippi. So there was a little bit of an upgrade for me, I guess, in terms of the healthcare layout. So when they recruited me to come practice here, what did they tell me? What did they do for me? We didn't have any talks about the healthcare situation in Rhode Island or reimbursements or whatever. They took me on the water, took me to Newport on the boat, they took me to Federal Hill for dinner, and they showed me what a wonderful state Rhode Island was. And I was sold. And so I came and I joined the practice here. And then I dragged my wife, who's from Wisconsin, who's also a dentist, to come to Rhode Island. But she doesn't practice in Rhode Island. She practices in Massachusetts exclusively, and she's a specialist as well. So I think some of the things that we need to work on is, from a dental perspective and from a medical perspective, is work on recruitment and retention of physicians, dentists, specialists in the dentistry world and in the medical community. I could tell you from personal facts in terms of our own society. I also happen to be the president of the Rhode Island Association of Oral Maxillofacial Surgeons. Our numbers are decreasing. You know, when I first came in the state around 2000, we had close to 40 oral surgeons are practicing, and now we have less than 30. So we've lost at least a third of the workforce. Since I've been here, I know of personally 10 office locations have closed. Now, these are office locations in good neighborhoods, good communities, East Greenwich, Providence, Smithfield, Warwick, and these retiring surgeons cannot find someone to purchase their practices. Recently, within this past year, we had 3 oral surgeons retired, and they were all in their 80s. I've practiced here for almost 25 years, and I'm probably one of the younger ones in our group. We do experience significant wait times, not only in the specialist office, but also in the primary dental offices. I think some of these factors that affect recruitment of well-trained individuals to come to the state are pay discrepancies, as we talked about earlier. I can speak to it firsthand, as I do have offices in both states, that if, I'll give you an example, if you have 2 children and you bring them to my Rhode Island office and then you bring them to my Massachusetts office, I will get 30 to 40% more for the same procedure, the same overhead, the same amount of time that's invested in performing those procedures. So there is a pay discrepancy, and that pay discrepancy will lead, and as we see, will lead to a shortage of practitioners. If you can perform the same procedures in the neighboring state and be reimbursed at a higher rate, any smarter individual, especially someone who's coming out with possibly 7 figures in debt, is likely going to take that job. So I think we need to become more in line with our neighboring New England states in terms of reimbursement rates, sort of the equal or level the playing field for Rhode Islanders. Another thing that we're seeing locally, as the primary care physicians discuss, is we see venture capital groups and DSOs come into the market. And I personally have spoken to them, and they offer a lot of money to buy a practice. And we see some of the older individuals are seeing this as an out. Previously, older practitioners may see selling their practice as a form of retirement and passing along to someone locally. We're not necessarily seeing that. We're seeing a lot of venture groups or DSOs buying practices in bulk, and that's going to change the face of dentistry. You're losing your neighborhood dentist, you're using your family dentist to now these corporately owned practices. And you may go in with a problem, and you're going to see Dr. Smith one day, you may see Dr. Wilson the next week, you may see another person the following week. And I think, as us being the smallest state in the country, that we should sort of foster that family dentist, the neighborhood dentist appeal to our citizens. So we'll have rotating dentists. You may not see the same person. The children of dentists, you know, we used to have a lot of generational practices where you get a second or third generation. There's lots of people who said, this is my grandfather's practice. We're losing that. You know, we're losing the generational practices. We're losing those children either told by their parents not to go into dentistry, or some of them that do are going outside the state. So they may go into dentistry because they may have the appreciation or like of the field, but they're not coming here for those particular reasons. It's now hard for the existing practitioners to sell these practices. There's, you know, the high debt from the graduating surgeon. They're going to get paid higher in the neighboring states that have the higher reimbursement rates. You know, corporate offices are more likely to start these people at a higher salary. So if you're coming out of school, you have a lot of debt, you may have a young family. The first thing that they look at is, what am I going to get paid day one? And it's hard to talk or recruit someone and tell them, look at the big picture, because they're looking at the immediate picture. I'm in this much debt. I need to make some money to pay down the debt, and then I can't afford to buy your practice later. You know, I have a lot of debt. Who's going to give me a loan when I have $600,000, $700,000, $800,000 worth of debt to buy the practice? So it's hard to recruit those individuals. Then they're very qualified individuals that should be practicing in the state, but we're not recruiting them. They're not coming in this state. It's also hard for us to recruit staff and as well as associates. You know, the cost of running practices, as we heard from the primary care perspective, is dramatically going up. They're, especially after COVID, I mean, every aspect of running a practice is going up. The supplies are going up, the cost of staffing, the administrative burden, the cost of living, you know, all those things are going up. And just from an anecdotal standpoint, I could tell you there's certain procedures that I performed when I first came to the state in 2001 that we're still getting paid the same rate, you know, 24 years, 23, 24 years later. There's inflation going on, prices are going up, so some procedures we're getting paid the same 24 years later. There is no training programs in terms of dental schools here. There's in our neighboring states we have some. We have very few training programs in terms of residencies. I think we have one pediatric dental residency at Rhode Island Hospital, and St. Joe's there may be some. I know Dr. King will touch more about the pediatric dental crisis when he follows me after I speak. But we don't have kids that are or dentists that are training here and want to stay locally. A lot of times people may go to a certain area of the country, they may do some additional training, and they tend to stay. So we don't have that benefit here in Rhode Island. You know, from a Medicaid standpoint, we have very few practitioners that participate in Medicaid. I know Dr. Kang will talk about from a pediatric standpoint, but very few practitioners, and especially very few specialists that participate. And I don't know many, or if any, oral surgeons that actually participate in the Medicaid program. You know, for me personally, it's easier just to do a pro bono case. I have certain dentists that may accept Medicaid, and I told them, just call me. I'm happy to treat that patient for free. We have certain programs, you know, that offer free care, the Mission of Mercy, Donated Dental, where we can offer our services to provide free care to people that don't have the means to pay for it or the insurances to pay for it. But it's just easier to accept no reimbursement than go through the administrative red tape to become a providing practitioner with the program. So there are some pay discrepancies between the federally qualified healthcare centers and private practice that I think trying to level the playing field would certainly help attract people and to help retain some dentists. I think we need to provide some incentives to the practices, you know, private practitioners in Rhode Island to keep them here or attract them here. Perhaps some loan assistance to private practitioners that may accept Medicaid and not provide loan assistance to those who that would work in the federally qualified healthcare centers. I know Dr. Kang will talk a little bit about the ambulatory surgery, as primary care physicians touched on it as well. We have difficulty getting cases into ambulatory surgery centers because the reimbursement rates are low, and you know these centers are not accepting the cases. So if we increase these rates to the facilities and we help cover some of the facility fees, they're more likely to accept these cases, dental cases that require some of them emergent care, whether they be you know, fixing infections or draining infections and removing teeth that are badly decayed, to just repairing a dental decay or root canals. So if we improve this, we'll improve our access to care in terms of providing adequate care for all the citizens of Rhode Island. So we have lots of patients that will utilize the emergency room or emergency department as their form of their primary dentist. And what that's doing is overpopulating an already busy emergency room that should be seeing people that are having strokes and cardiac arrest or fractures or whatever they may be. People with dental needs shouldn't be going to the emergency room. We should be able to triage them, see them, keep them out of the emergency room, and treat some of their issues. And some of them go go far advanced. You might have a tooth that has some decay in it, and then that decayed tooth hurts a little bit and becomes an abscess. That abscess can spread into the neck, and from the neck it can spread into the chest, and it can become a fatal event just from a toothache. So, in summary, what I would say is that dentistry shares the same concerns as medicine and should be included and have a seat at the table when discussing health care. I think we should recognize oral health as part of one's general health and not be separated from the two. I think promoting a relationship with the dentist and the physicians in terms of improving overall health will certainly benefit the citizens of Rhode Island. And when we ignore dental care, as I told you earlier, that these things just complicate the healthcare system. They put a large burden on the healthcare system, and we overburden the ERs. So good preventive care will decrease the ER visits, and we will, recognizing the crisis now to prevent further crisis is really what we should be doing, with the increasing age of our dentists and decreasing number of dentists are coming into the state, that we're on a crisis and we need to fix it. So thank you again. I try to keep it short and brief, but thank you.
Thank you, Dr. Paletta. Next, I'd like to ask Dr. Kiang, dentist from the pediatric dentistry and surgery.
Everyone seems to be fiddling with the mic here, so I'll try not to do that and just kind of get it settled. My name is Dr. Kiang, or John Kiang. I am a pediatric dentist here in Rhode Island and in Massachusetts. I am proud father of 2 young ladies. And just to get a sense of the room here, if you could raise your hand, how many of you have children or have children? Thank you. So the vast majority of our people here today. My training and my background, I trained here in Rhode Island in Providence at the St. Joe's Community Health Center after working as a community health public dentist here in Rhode Island at Blackstone Valley Community Health. Went on to do a pediatric dental residency, and I stayed because I love coffee, milk, and dills, Dr. Brown. But in reality, I stayed because I loved Rhode Island, I love its citizens, and I wanted to raise children here. A little bit of a background of what I've done since then. I was the past president of Rhode Island Dental Association, and I am currently the president of the Rhode Island Oral Health Foundation, which puts on the Mission of Mercy every year. I won't belabor what pediatric dentistry is, but if you could just indulge me for just a couple of minutes, because I think there is a misconception of what we do. Many of you, I hope, go to the dentist and you see your general dentist, at least twice a year for your routine cleanings. But it's a little different from the pediatric dental perspective. We do teach our little ones good oral health, but the majority of the patients that we do end up seeing are referrals from general dentists and or our community health centers. And a lot of those children have medically complex backgrounds, whether it's cardiovascular issues, connective tissue disorder issues, and it just really runs the gamut, which a large part in which we do as a pediatric dentist is to get these children comfortable and treat them in an appropriate way. Now, a lot of these children are healthy. They have great mouths, perfectly fine. That is the bread and butter of kind of what we do. But we also treat kids with significant dental issues. A lot of the children that we do treat either have syndromes that have an oral component related to them, and or they have decay. Now, a lot of times I hear this from parents, right? They come in, the kid, we take some x-rays. Unfortunately, they have a few cavities, and we hear, well, they're just baby teeth. I think they're gonna fall out, right? And some of that is true. Some of that, we have a 10, 12-year-old small cavity, tooth is gonna fall out 6 months, no big deal. We're kind of, we might monitor that and see how that goes. But the majority of the children that we do see, unfortunately, and the highest increase of rates of dental decay is within this kind of 5 and under category, right? They're kind of these little gremlins who are always running to the cabinets and always telling you they're hungry, and they have a cup of Oreos, and they're walking around all day long, and unfortunately, it will experience some decay if their teeth are not appropriately taken care of. They need them for aesthetics, to eat, function. These baby teeth act as placeholders for adult teeth in the mouth. We have 20 baby teeth when we're little, and we have 32 teeth as we become an adult. So if we prematurely lose any one of these baby teeth, it creates complications down the road for them. Missing teeth, you need some orthodontics later on to move teeth appropriately to get them back into function. Now, I'm gonna show some pictures. A lot of these pictures on my slides here are not for shock value. This is what we see daily in the office, and it becomes a situation in which we have a very small child who has dental decay, and we need to kind of address that issue. I don't know if you guys are aware, but it is the most common infectious disease amongst children. It is more prevalent than asthma. A large proportion of kids from kindergarten to 3rd grade have dental decay. It's some on the lines of 40%. That is really high. Now, I'm going to delve a little bit past this into severe early childhood caries. Now, this is a patient that I had brought to the operating room to treat their dental decay. Now, when I talk about bringing children to the operating room, I'm not just talking about 1 or 2 fillings that need to be done. I am talking about gross decay. 20 of 20 baby teeth have decay, and they need to be restored. Either restored, extracted, pulpotomies, which is like baby root canals. All of these procedures are done within that setting. I will get on later on into how many children this is affecting in Rhode Island and what we're seeing and what we can do about it to make it better. Now, this really severely impacts their quality of life. A large majority of you raised your hand that you have a child. Imagine your child walking into the office, or you see them in the middle of the night, they wake up with this facial swelling. It is severely impacting their ability to eat, sleep. There's failure to thrive issues. I've treated children, 2, 3 years old that had mouths like the previous slide, and they were underweight. They are crying, they're being irritable. A lot of these things are severely impacting. Imagine if this was your child. Now, majority of the time, we try to do the dog and pony show in the office, right? We don't want to necessarily take kids to the operating room unnecessarily, but we use this kind of, show and tell, show, tell, do. I'm basically like a clown half the time throughout the day to make sure that these 3, 4, 5-year-olds, 6-year-olds, 7-year-olds are gonna not hate the dentist. True story, I hate going to the dentist. I am the child of immigrants. They came here, we had very little money, and I had some dental decay as a kid. It was pretty tough. I remember, to this day, being held down to have some fillings done. It's the reason I became a dentist. It's the reason I became a pediatric dentist. It's the reason why we need to treat kids appropriately. Now, I'm going to talk about the extreme, those extremes that we had talked about. We had seen those pictures. What do we do in this case? We tried to bring them to the operating room under general anesthesia. Sometimes this is the only way anything is going to get done. And sometimes we treat children who are severely autistic, combative, unable to sit in the dental office. Now, what do I tell those parents who say, well, everything looks okay, but Jimmy punches and hits you, or punches and comes when he comes into the dental office? Those kids need to be sedated as well. And to do that, the rationale behind it is we're able to treat them in a compassionate way. They're not, unfortunately, they are asleep, and we are able to kind of treat them in a fashion in which we're doing good quality care, and the child is psychosocial is being also a large component to what they do. I won't even go through all the indications because I think you all are smart enough to really, truly understand to what the point I'm getting at here. I did want to talk on our inpatient versus outpatient setting because I will touch on this later on in our ASA classification. So if you have a healthy kid, no other comorbidities, we usually are able to kind of treat them. We can treat them in the operating room, or we can treat them in an outpatient surgical setting. Here in Rhode Island, the outpatient surgical setting is not an option. I will get to later on as to what we can do to combat it, but unfortunately right now, whether your child is medically complex or healthy, they're all getting shuffled into the operating room. That is not the appropriate way to be treating these children. Those operating rooms should be for our very sick kids that need to have some dental procedures done. That is the appropriate setting for that. I'm going to touch on one thing here that is not on the slide. In Rhode Island, if you have a medically complex child who needs GA for dental services, they are unable to be seen here. There are 2 hospitals in Rhode Island that do allow dental procedures. I'll have a slide on it, but it's Fatima Hospital in North Providence, and it's Hasbro Children's Hospital. Now, Hasbro Children's Hospital does treat they do a fantastic job of treating a lot of our medically complex patients. They do not accept referrals at the moment. Only their inpatient, their community in which they have already established, so they treat their patients appropriately. But I have a child right now in my office who has a medically complex background. I'm unable to refer him to Samuel's, which is part of that Rhode Island hospital for GA services. No other hospital will see him. I'm trying to bring him to UMass in Massachusetts to be seen. And there is a plethora of paperwork involved that is inhibiting me from bringing that child there. He's on the state medical insurance, and the red tape. It's been 4 months. 4 months I've been talking to this mother about how we're going to try and receive care. He's been on 2 rounds of antibiotics. He needs 4 extractions and at least 5 other teeth that need to be restored, or he's going to have 9 extractions at this point. What am I to tell that mother? We need to do better. Everything that we do in the operating room, we're just doing comprehensive care, right? We're cleaning their teeth, we're taking x-rays, we are restoring those teeth, we're doing everything possible that we can to fix them, get them back to a good, healthy state. Now, where are we right now? I actually looked at these numbers at the past 2 days, so forgive me if I don't have them memorized. But there's not a lot of good dental statistics. Dr. Schwetzenbaum does a fantastic job of trying to get those, but we all work in our own little silos and we don't have those numbers. And so I used the data reported from Kids Count, but basically the short of it is dental decay is on the rise. Emergency room visits are on the rise. These are all avoidable things that we can be doing. Dr. Stepka, who's a general dentist in Cumberland, does the Rhode Island Providence schools. He is the school doctor. In Rhode Island, K through 5, I believe, has to have at least an annual visit, or the dentist has to at least check their mouth. He is seeing alarming rates just here in Providence of dental decay decreasing. I won't even get into the big numbers, but right now, according to his data, there are 500 kids who need urgent care. We are failing these children. So I had a conversation with a colleague recently. You know what it's going to take, Dr. Kiang? No. It's going to take someone dying in this state for someone to do something about it. I don't want to be that guy or that alarmist who stands up here and says that, but I'm also very worried at the condition in which we are at right now. And this is just Providence statistics. This does not even cover the state. Now, I wanted to touch on where's the access to care problem. What's happening right now, and what can we do about it? It's easy to say we have all these problems. What is the solution? Where can we go from here? And so like I mentioned earlier, there's only 2 facilities that are doing GA cases, one of which may be sold in the next upcoming months. That worries me. Is that going to reduce any of our operating time in the future? So what can we do to improve it? Well, there's a bill being set forth for our Medicaid patients. It's 2571, S2571. Is that correct, Senator? Yes. What this bill does, because this is a nationwide problem, it's not just Rhode Island, they've created a code, a G0330 code. The reason why we cannot utilize our outpatient surgical centers that had the availability to do these procedures there is because they're just not reimbursed. It's not recognized. A dental procedure in an outpatient surgical center is not a recognized procedure. I don't know why I didn't create the rules, but they created this code so that they can bill this, so that we can actually open up another avenue where we can take these kids to receive faster, appropriate care than what we're doing currently. If you were able to come to my office tomorrow, or today, this afternoon, I'm going back to work after this, and you have a child that needs GA services, they have extensive needs that need to be done, I'm at least telling you, and my practice has an OR block, which is very rare in Rhode Island. I'm telling you at least 4 or 5 months. You need to handle it, Mom. I'm sorry. If there's any infection present, I'll give you an antibiotic. We can work through that. If you need an immediate extraction, maybe we can get that done for you. We have limited amount of oral surgeons in this state, and they are completely overwhelmed. So the wait time at a quote-unquote private practice is at least 4 to 5 months. Now, imagine the child who doesn't have a dentist, who's living in Providence right now, one of those 500 kids. He is now going to be he'll get referred to a community health center. They will try and treat that kid. If they're unable to, he's going to get referred to one of our offices. By the time that happens, months have gone by. We need to do better at getting these kids the appropriate treatment in an appropriate, faster way that we're doing it. If you need anything, my cell phone number's there. Please reach out. Thank you.
If we can hold our questions, we're now going to hear from the 2 hospital systems. To begin, Dr. Michael Wagner, President and CEO of Care New England, and Dr. John Hernandez, President and CEO of Lifespan Health Systems.
Have a seat. So we thought this was a good time to have 2 rays of sunshine talk with you. Ha ha. Okay. So it is great to be here. I want to acknowledge Senator Whitehouse, Attorney General Nerona, Speaker Shekarchi, Senate President Ruggiero, Secretary Charest for the opportunity, and Lynn, thanks for coordinating all this work. First thing, I'm going to try to go through this rapidly because I want to be able to get back on time. First, I want to thank the teams at each of our organizations at Care New England, about 8,000 employees that come in every day to make sure we provide the most compassionate, high quality, and equitable care possible. I want to thank them for their tireless dedication to our mission and to our patients and to each other. Major points that I want to make is that the Rhode Island healthcare system, as you've been hearing, is stressed and fragile. We've come out of a global pandemic, and for us, years of distraction due to merger discussions. This is also a time in medicine that we're seeing some amazing advances in diagnosis and therapies and the ability to help people lead healthier lives. But we have to also recognize that we live in a regional marketplace that includes Boston, Worcester, and 2 large systems in Connecticut. And over the past 10 years, those systems have advanced, while Rhode Island has not. Given our size and the willingness to make a difference, as is evident by today's summit, Rhode Island has probably the greatest potential to be a model on how to do healthcare right. But we need to focus on the foundational aspects of healthcare delivery and stabilize our healthcare system, and that's what I will mostly focus on. At Care New England, we made a commitment to remain independent and to build on the strengths that we have in women's healthcare, newborn care, behavioral health, geriatrics, primary care, community acute care, and population health, really the foundational aspects of healthcare delivery. After many years of distraction, we've stabilized our financial position and have become profitable on operations. We're now hardwiring performance to bring rigor back into the operations of the organization, and this is necessary given the distractions of the last several years. We'll accelerate our work here. Mary Marin talked about the opening of a 25-bed short-stay unit, which will help the issue of behavioral health patients boarding in our emergency rooms across the state. We've added a new labor and delivery unit at Women and Infants to create an experience for people who are delivering that's at the same level of expertise that our nurses, doctors, and entire staff provide at that hospital. And we continue to make Kent Hospital age-friendly with the acute care for the elderly program, the Kent at Hospital, Kent at Home program, geriatric certifications in the emergency room, and now for the ORs. This has given our team the ability to step back, think about where we're going and what we need to focus on. So I'll make a couple of comments that have to do the intersection of our strategy with the state. And there's a couple of areas that I think require focus. And I'll talk about Medicaid, primary care, health equity, and focused planning. What we're not going to be doing is looking at mergers, just to be clear. We have been very distracted in those merger discussions, and we want to stay laser focused on what it's going to take for Care New England to continue to do the work that we need to do and be a partner to the state and all of the organizations to be part of that solution. We also believe that we can't solve all of the issues, and we need to focus on some key issues that have a broad and wide-ranging impact across the state. Medicaid. Based on the recent Rhode Island Foundation study, Rhode Islanders, we have a proportion of Rhode Islanders on Medicaid and self-pay that's at least 5% higher than Connecticut and Massachusetts. 5% may not sound like a lot, but if you substitute 5% of Medicaid or self-pay or uninsured for commercial, that will have a dramatic positive impact in terms of reimbursement at the hospital and physician level. Understanding that why we have such a high portion and what we can do to help people move more into the commercial market is probably one of the most economically prudent things for us to do as a state. The other piece on Medicaid is the reimbursement rates, and that is something that's before the General Assembly around how do we increase rates today. We have hospitals that are highly dependent on Medicaid reimbursement, and how do we maximize and optimize the federal match? We should be taking advantage of every bit of federal match possible on Medicaid. Primary care, I'm not going to delve into this deeply because my two esteemed colleagues, Dr. Brennan and Schulman, gave you a passionate plea for the plight that our primary care physicians, sorry, that's a bit of an alliteration, for that our primary care physicians are going through right now, and it is incredibly stressful. Primary care is under duress nationally in Rhode Island, although statistically, if you look at the state statistics and compare us to the other 49 states in the District of Columbia, it looks like we have a number of primary care physicians per thousand that's enviable. The problem is that doesn't make up for the history that you all feel when you get called by a family member or try to get access yourself that your doctor is just retired or is moving to another state, or access is going to take a long time and you need a special connection to get in with that primary. That's the reality, and I wouldn't say the rest of the country is leading in this, and we are certainly in a position where we have to rebuild primary care capacity. We can't be reshuffling primary care physicians within the state. We actually need to create an environment which is attractive for primary care physicians who either train here to stay here or who get recruited here to come. And the doctors outlined many of the challenges that make it very difficult for us to recruit physicians into the state. Compensation matters, and that's where reimbursement comes in. And for some physicians and practices, they would want to see that directly from the compensation for the physician. In other practices, they will want to see us build team-based models so that they can do their work in a team-based environment. What we need to do is to increase compensation to give the optionality to primary care practices about how's the best way for those dollars to be used to support the mission that they're undertaking in primary care. The last piece I'll raise is the issue regarding medical malpractice in the state. We recently went out and looked at our reinsurance opportunities, and we're bluntly told by the international market that Rhode Island is a hostile state. And although they were very interested in the work we were doing in terms of risk mitigation and our med-mal program, they weren't interested in working with us because of the state we were in. We need to create a friendlier environment for our physicians and hospitals regarding med-mal and tort reform. There's two bills in front of the General Assembly. One is the I'm Sorry bill, and the other is a task force to evaluate tort reform, and I encourage the General Assembly to pass both. I'm almost done. Health equity. At Care New England, we made a commitment to specifically look at the disparities in healthcare. As you all know, that there are differences in outcomes for Black and brown individuals, and we need to take this as a call to action. Our focus has been on three core components: diversity, equity, and inclusion, health equity, and community engagement. Why diversity, equity, and inclusion? Because people tell us that they want to see people who look like them, that talk like them, that know their culture. They want to see that in our organization. That's why diversity matters. And it's also important for us to create a belonging environment so that we can create a better connection with our patients. Health equity, we know that populations are not having the quality measures that we've talked about, we've looked at. Diabetes measures, hypertension. We know that people, Black and brown individuals, are not getting the same level of process and outcome measures. We also know that in Medicaid, the expectation isn't that even the Medicaid population achieves the same level of commercial and Medicare performance. That's actually part of the expectation. We took that specifically as a challenge and said on our Medicaid quality measures, we would want to approximate performance on the Medicare and commercial side. I would encourage my fellow leaders in the organization to make a health equity and disparity objective part of their executive goals. Lastly is focused planning. There is so much that needs to be done, and today's forum is a great way for us to air a lot of those issues, but what's really remarkable is our willingness to come together and hear the stories from the other parts of the health organization and recognize that we have a lot of work to do. In addition to the areas that I mentioned earlier, ensuring a stable hospital services across the state is vitally important. If you look at the number of beds per thousand, the state of Rhode Island compared to the other states around the country, we rank at 49 or 50th. The loss of Roger Williams and Fatima from a hospital capacity perspective would be devastating in terms of access to acute care services. And come to a resolution, I look forward to Attorney General's comments, not to put you on the spot there, General, but around the charter care issue. We see in Massachusetts that as bad as charter care issues are for us, Massachusetts has 8 hospitals that are part of an organization that has gone into bankruptcy. We need to create a fast path for charter care to sustainable operations. And lastly is a data-driven, evidence-based approach. Let's use data and evidence and cost effectiveness to drive our decisions. My final comment is that I like to say back at Care New England that healthcare is distilled down to the interaction between two people, a patient and their caregiver. Our job as leaders is to create the environment where that can happen in the best way, that the caregiver can be totally focused, and as you've heard from the physicians and the dentists, the fact that there's a lot of administrative work around their activities means that they're distracted. It's not just the insurance side. There's all sorts of pieces that are affecting the ability of our caregivers. And it's not just doctors. It's the advanced practice clinicians, it's nurses, nurse navigators. In fact, I like to say that everybody, the 8,000 people at Care New England, are all part of the healthcare team. And if it's the person that's cleaning the room or bringing a tray into a patient, they're part of the team. And if it's the person walking down from the finance department who has no patient activity and notices a patient and a family member that look lost, and God knows hospitals can be very confusing places, is that they actually stop and say, how can I help you? I would like to encourage all of you to see yourselves as part of the care team. Your job is to help us figure out how to create an environment where the caregiver and the patient can have the best interaction possible. Thank you.
Can you hear me? Yes. Great. I'm going to bring some optimism to this. I'm the son of a minister and a politician, so I have about 20 pages here that I'm going to go through, and I actually do have that many pages, but they'll be available to you on email, and I'm going to hit the highlights because I think we've covered a lot of the details here, and like Mike, I can't wait to hear from my insurance colleagues and the Attorney General. So my message is simple. We need more money for Medicaid funding, period, and we need to create jobs in this state. Those are the two things. If you leave here today wondering how I feel about it, there are 100 other things that came up today that I could talk about, but these are the two things. And then I would say on the operating side, my favorite, I was going to put a slide up. I have a t-shirt. It's called GSD, Get Stuff Done. And we need to focus on getting stuff done. The time is now. The time is to think of this, all these things you hear. We do have a crisis. I'll list a few facts that I'm going to add to Mike's. But we do have a crisis. We need to use that crisis. There's nothing like a good crisis to turn it into an opportunity. Let me give you an example of some of the additional crises on the payment side. So why Medicaid rates? If you look at other states, and there's a reference in the document we'll circulate, we are at 37% of Medicaid, compared to Massachusetts and Connecticut that are at 75 and 78% of Medicare to Medicaid rates. By the way, Medicare is no good either, but it's better than Medicaid. So to be at 37% of Medicare, the senator, we're still here, the last 2 years, Medicare's gone up 1.7 and 1.6%. Anybody think inflation's going up that slow? It's not. So we have some structural things to get over, and that's just an example. And at Lifespan, to put that into numbers for you, our Medicaid operating margin is negative $139 million. You throw in some charity care at $32 million, that adds up to $170 million just on those two populations. We shouldn't have to lose money taking care of people, which I loved Mike's last comments about what are we here for. I always tell my staff, we are here. The leadership is here to make it easier to take care of patients and make it easier to do research, period. So Mike, that was awesome. By the way, I'm going to steal that for a future speech. So the other thing, I was asked by the Speaker's office, could I make a couple comparisons to Massachusetts, of which I worked there for about 30 years at Brigham and Women's Hospital, and then CEO of Mass Eye and Ear. And I'd say there's one thing in Massachusetts that they have what they call a public, a high public payer hospitals. And the state gives those hospitals a little more funding. It's actually not a little. It's about $290 million a year goes to those public payer hospitals. And if that was true in this state, two of the hospitals in Lifespan would be members of that, Rhode Island Hospital and Miriam. Let me share three. Yeah, I am running a public hospital and a public service, proud of it. That's where the son of the minister and the politician come in. But I always tell people, my friends from Massachusetts say, well, what's Rhode Island, what's the Lifespan like? And I said, it's sort of like a merger of the Brigham and Boston Medical Center. A big public hospital and a private doing the same. But in my two examples I'm going to give, as a public hospital, we're the last resort. We have a patient today, been in the hospital 300 days, doesn't need to be in the hospital. When I first got here, within 2 months, we discharged a patient that had been in the hospital for over 1,000 days because they had no place to go. They had no home. They didn't have the right payer. We can't, as a hospital, run with hundreds of patients there for days that they don't need to be in the hospital. By the way, it's really not, I love my hospitals, but it's not a great place to be. If you can avoid coming to a hospital, that would be great. So those are my quick stories of a few of the people that have been hurt recently, spent 300, 400, 500 days in our hospitals. We need to have a better system to deal with that. Last but not least, I'm going to make a shameless plug. I think, is Neil still here? We need to create more jobs in the state. And that's from a selfish healthcare point of view. We need more people with jobs that have insurance, so that payer mix that Mike talked about. By the way, this ray of sun, Sheldon, if you were here, us as rays of sunshine, oof, that's rough. My dad's going to give me some grief on that one. So back to the jobs. The Rhode Island Life Sciences, good start. But we need other sectors. We need more money there. That's the way to create jobs in the state. I'm all in on creating more jobs. Just give me a call. So last but not least, I want to thank the Speaker, Senate President, and everybody here for hosting us. Lynn, a big thanks. I know we're running late, so just remember, more money for Medicaid, more jobs. Thank you very much.
Thank you both very much. Next, I think it's a perfect segue for our payer mix. And first, we'd like to have Martha, the President and CEO of Blue Cross and Blue Shield of Rhode Island. Martha Wolf.
Thank you. I will try to be brief as well and follow your great leadership. I wanted to thank Speaker Shekarchi, Senate President Ruggiero, and Lynn Urbani for the opportunity to speak. I'm Martha Wofford, the President and CEO of Blue Cross and Blue Shield of Rhode Island. And I just wanted to start by saying at Blue Cross how proud we are to serve Rhode Island businesses and members. We are also proud of our deep local role in the community. And we're cognizant of the challenge, the struggles that people and businesses are facing in the state with the high rate of insurance and including medical cost inflation. I'm also incredibly proud of the partnership that we have with the providers, where we are working together to shift towards more stability for the providers, particularly after the pandemic, where we're investing in primary care, which we heard a lot about today, and where we are seeking to improve the predictability of healthcare spending for both the providers and for the ratepayers. I would say that there's an inherent balancing act, as I think we all are aware, between affordability for people and for the stability for providers that we all seek. At Blue Cross, ultimately, what we provide is access to the healthcare system. And so what we want is a strong, stable healthcare system that the people of Rhode Island can afford and can access. I've had the opportunity to work in healthcare across the country, and so I was asked to just provide some commentary of what I see here in Rhode Island. And I would say I see two big structural issues. The first, and again, I'm going to echo a bit of what Mike and John just said, which is that we have a disproportionate share of government-funded healthcare in the state of Rhode Island. So we have 70% of people who are covered by Medicare and Medicaid. And so Massachusetts is 65%, but there are some states that are closer to 50%. And so I think people know this, but if you don't, this really matters because commercial insurance pays twice what Medicare pays and much more than that, what Medicaid pays. And so what happens is that commercial insurance subsidizes care for all other people. And so we really need that cross-subsidization to make sure the healthcare system works and that the providers can cover their costs. And we don't have that right now. And so what can we do about it? As the Speaker and Governor said, as John just mentioned, at the Life Sciences Summit last week, we talked a lot about how do we bring more good-paying jobs to the state of Rhode Island. And that is absolutely critical. Jobs with living wages. The Speaker's work on affordable housing is another key ingredient to make sure the people of Rhode Island can afford to stay here. And we need to adopt more policies to drive economic growth. And layering in mandates such as healthcare ones that maybe require coverage for specific services without cost sharing or a specific disease state are well-intentioned, but they actually do the opposite. They raise costs which raises premiums here and pushes companies to locate workers in other states or not hire. This makes the problem worse, further shrinking the commercial population in Rhode Island. And this puts even more pressure on providers. The second big structural issue is that government reimbursement is disproportionately low in Rhode Island. So not only are there too many people on government insurance for every commercial patient, but every government patient is reimbursed worse in Rhode Island than other states. So what do we do about it? We need to continue to invest to bring Medicare provider rates up. I commend the governor for the progress in his budget, the $110 million in investment in directed payments that the hospitals worked on with the administration, the $55.5 million for social and human services. We need to do more, though, to get rates to come close to covering costs. And I know raising Medicaid rates puts pressure on the budget. But for every dollar we raise provider rates, the state only contributes 35 cents and the feds contribute 65 cents. It is just smart to maximize the federal dollars and bring home more dollars to Rhode Island. At Blue Cross, we support the legislation to have OHIC examine appropriate pay of primary care by Medicaid. At Blue Cross, we believe it's critical to invest in primary care. We've heard a lot about the challenges primary care is facing. And by investing in primary care, we can increase preventive care, access to team-based care, provide more support for complex patients, reduce unnecessary expensive hospitalizations, and I agree with you, John, that nobody really wants to be in the hospital, and I think the hospitals would rather have more complex patients than the ones that could be treated out in the ambulatory setting. We need to integrate behavioral health into primary care, as Mary Marin said. We need to reduce the utilization of specialists. We're at 125% of regional benchmarks and far higher than that of national benchmarks for orthopedic use here in the state. We need to reduce the administrative burden, particularly on PCPs. We need to keep care in Rhode Island when clinically appropriate, so we're investing in our local providers. We need to reduce the cost of specialty pharmacy through how we purchase and manage medications. And we have to improve the quality and fairness of care. We have very high rates of drug and alcohol deaths in this state. We're 34th for severe maternal morbidity. That is a critical racial health equity issue that we need to address. I want to commend the Senate President for his action on lead poisoning from pipes. It's an important area of racial and income disparity. At Blue Cross, we've invested over $500 million in primary care in the last 10 years above the rates that we spend. We are committed to continuing to invest to help primary care thrive, and we are seeing some positive shifts from our value-based care capitation programs that pay physicians prospectively each month. This increases the ability for those practices to thrive, to hire physicians and take on more patients and open up their panels so that members can have more access. We'd like to see the pace of investment in primary care accelerate. I've had the opportunity to work in markets where value-based care works really well, and those practices do phenomenally well. So while we're still in the early stages here in Rhode Island, it unlocks a whole new world for physicians, for nurse practitioners, for the whole care team, where they get off of that sort of treadmill that unfortunately folks are on. There is a recent bill here trying to tie Rhode Island rates to neighboring states, which would cost Rhode Islanders $500 million annually of incremental cost. That would increase the average premium for a family of four by $4,000. And this is a prime example of a mandate that would make Rhode Island less attractive for job growth for employers and further shrink the percentage of commercially covered healthcare workers, and really importantly, crowd out wage growth for workers. So while that's bad policy, I do believe there are 5 things that we can do together to improve the situation in Rhode Island. First, continue to address the structural issue of low Medicaid provider rates, so we maximize federal matching dollars and create more stability for providers. Secondly, continue to bring facts to the table, enabling data-driven discussions in partnership with providers. Importantly, we need to look at physician and pharmacy reimbursement, the other 50% of healthcare spending that has not been analyzed, and to look at workforce development to understand our gaps and address policies to close them, such as loan forgiveness. We need to speed up the investment in primary care so we can ensure Rhode Islanders have access to primary care. Fourth, we need to continue the good work around the state on affordability, quality, and equity, 3 areas of vital importance to the people of Rhode Island. And lastly, and most importantly, we need to do everything in our power to drive job growth. At Blue Cross, we appreciate your partnership. We appreciate the collaboration in our small state. We appreciate your trust in us as an insurer. And we continue to embrace working with the provider community, labor, the business community, and policymakers to get to good, balanced approaches for the people of Rhode Island. Thank you.
Thank you very much, Martha. Now, at this time, we'd like to invite our Medicaid Program Director, Director Kristen Souza, and Secretary Charest sends his regrets. He's not well today, but certainly Kristen is very capable of delivering his remarks as well. Thank you.
Thanks so much, Lynn. Good afternoon. I was going to say good morning, but good afternoon. I am Kristen Souza, the Rhode Island Medicaid Director, and I want to thank the Speaker, Mr. President, Senator Whitehouse, and all of the participants of this healthcare summit for the opportunity to share these remarks, some details about the Executive Office of Health and Human Services and the Rhode Island Medicaid program with you. Unfortunately, Secretary Charest is ill and unable to join us this morning. He has asked me, however, to send his apologies and that I highlight some of the healthcare-related items he planned to address today. EOHHS is designated as the single state agency responsible for the administration of the Medicaid program in Rhode Island. It is also the principal agency responsible for providing strategic guidance and oversight of BHDDH, DCYF, Rhode Island Department of Health, DHS, and the Offices of Healthy Aging and Veterans Services. While we work across the Secretariat, it varies greatly. Our mission is the same: to foster and strengthen a community-driven, equitable, comprehensive, responsive, and high-quality health and human service system in Rhode Island. Just like many states across our nation today, Rhode Island's healthcare system is challenged by disparities in reimbursement rates, provider needs, workforce shortages, access, and quality outcomes for some of our most vulnerable communities. The good news, however, is that there are many examples of excellent work happening at the state level this year and on behalf of Rhode Island's healthcare system. For example, our Medicaid renewals, thanks to the efforts of our interagency team and hundreds of partners, including the General Assembly, Rhode Island just completed a successful one-year cycle of restarting the annual Medicaid renewal process. Our interagency state team developed and executed an extensive public awareness campaign and worked closely with a variety of stakeholders to remind Rhode Island Medicaid members how to renew their coverage. This model effort was enhanced by a coordinated and thorough partnership between the executive and legislative branches, including elected officials and their respective staff. Our CCBHC initiative, our interagency team and providers are working towards an October 1st start date for certified community behavioral health clinics, a national set of standards for comprehensive behavioral health care that is jointly supported by CMS and SAMHSA. This is a once-in-a-lifetime opportunity to make generational change to the behavioral health system in the state. CCBHCs will enable us to build a stronger, more accessible, equitable, and sustainable behavioral health system for all Rhode Islanders. Our nursing home stabilization, Governor McKee's FY25 budget calls for $10 million in state fiscal recovery funds to help stabilize nursing home providers. from July 2024 until additional rate increases go into effect in October. Our state-directed payments. In January, we announced that the federal CMS approved new state-directed payments to hospitals to promote access and quality. For the FY24 budget, Governor McKee proposed and the General Assembly passed new state-directed payments to hospitals through our MCOs. These new payments, combined with changes to other supplemental payments and taxes in the FY24 budget, resulted in over $110 million in new Medicaid funding to our state's hospitals. Since Medicaid rates are often lower than commercial insurance rates, these new payments will help close gaps between rates and provide hospitals with additional financial support. Governor McKee has included these payments again in his FY25 budget. The launch of the Mobile Response Stabilization Services Program has been a major win for providing mental health services to youth in crisis. This program provides time-limited, on-demand crisis intervention services in any setting in which a behavioral health crisis is occurring, including home, school, and emergency departments. Depending on the needs of the child, the stabilization component may include a temporary out-of-home crisis resolution in a safe environment. To date, 90% of the youth in this pilot program did not end up requiring psychiatric hospitalization. Moving into the next fiscal year, Secretary Charest asked me to quickly review his healthcare system planning effort that is currently underway. As a state, we would like to, with all of your partnership, respond to any of the gaps and challenges we have in the current healthcare delivery system through a more unified approach. There are already numerous committees, advisory groups, and work teams focused on health system planning across state government. EOHHS and our state and community partners have carried out a broad range of planning activities over the years. Some of these groups include the Governor's Council on Behavioral Health, the Infant and Early Childhood Mental Health Task Force, the Rhode Island Children's Cabinet. We also have amazing healthcare system data and robust reports about the current state of our healthcare system from organizations like the Rhode Island Foundation and CTC Rhode Island Primary Care Workforce Task Force Strategic Roadmap. That's a mouthful. As part of the Rhode Island 2030 plan, which includes several goals related to our state's healthcare system, this spring, Governor McKee signed an executive order establishing a state healthcare system planning cabinet. As the healthcare system planning cabinet lead, Secretary Charest's goal is to pull these planning processes together and establish a way forward that further stabilizes and strengthens our system. Part of the new healthcare planning process includes crosswalking and aligning these existing planning groups and initiatives into an overarching roadmap for additional healthcare system improvements in Rhode Island. There have been a couple of cabinet and independent advisory committee meetings to date, and we look forward to presenting a report with recommendations on next steps to strengthen our healthcare system to Governor McKee by December 2024. I will bring back today's conversations to the Healthcare System Planning Cabinet so we can incorporate your thoughts into our planning process. One of the most important things we do as state leaders is remain in communication with our healthcare leaders as we are partners together in ensuring Rhode Islanders receive comprehensive, equitable care that best meets their needs. We cannot operate in a vacuum, and we must ensure that all our efforts have our partners at the table. These are difficult times for the healthcare sector, and the complex challenges we face require solutions from federal and state government, the General Assembly, the private sector, academia, and advocates, while truly listening to the needs of the people we serve. I will now say a few words about the Medicaid program. The Rhode Island Medicaid program has a profound impact on our state's healthcare delivery system. Medicaid is the foundation that upholds the health and well-being of countless individuals and families across our state. serving nearly 328,000 individuals, I firmly believe that the Medicaid program drives the overall healthcare delivery system in Rhode Island. Medicaid serves as a safety net, catching those who might otherwise fall through the cracks of our healthcare delivery system. It provides access to essential medical services for low-income individuals, children, pregnant women, seniors, and people with disabilities. By ensuring that these vulnerable populations have access to health care, Medicaid plays a pivotal role in promoting health equity and reducing disparities in our communities. Without Medicaid, many Rhode Islanders would struggle to afford the care they need, leading to worsened health outcomes for individuals and increased health care costs to our overall health care system. Medicaid also serves as a critical source of funding for healthcare providers across the state. Healthcare facilities, from hospitals to community health centers, rely on Medicaid reimbursements to sustain their operations and provide quality care to patients. In Rhode Island, Medicaid is the largest payer for healthcare services, covering a significant portion of the costs associated with treating patients. Medicaid serves as an economic engine, generating jobs and stimulating economic growth throughout the state by providing coverage to approximately a third of Rhode Island's population and half of the state's children. Medicaid supports a vast network of healthcare professionals, administrators, and support staff who contribute to the state's economy. In addition, Medicaid funding flows through local healthcare providers, pharmacies, and other businesses, creating ripple effects that boost economic activity and create employment opportunities in communities across Rhode Island. Furthermore, and with the partnership of the Governor and the Rhode Island General Assembly, we have the ability to leverage federal dollars to expand the capacity of Medicaid programs and strengthen our provider network. Rhode Island Medicaid is not just a health care program. It's the cornerstone of our healthcare delivery system, driving improvements to access and quality. By ensuring access to care for vulnerable populations, supporting healthcare providers, fostering innovation, and stimulating economic growth, Medicaid plays a vital role in promoting the health and well-being of our state. As we look to the future, let us continue to recognize the importance of Medicaid and work together to ensure that all Rhode Islanders have access to health care they need and deserve. I think I can provide some additional Medicaid information if I can't really see the deck. Is it up? No. Okay. I'll just speak to it quickly. For folks who are unfamiliar with Medicaid, which I'm not sure anyone in this room is, it was established back in 1965 as part of the Title 19 Social Security Act. There have been several improvements to the Medicaid program over the years, most notably for us, the Patient Protection and Affordability Act, signed by President Obama, allowed us to expand Medicaid to low-income adults without children. Rhode Island was one of the first states to take advantage of that, and we do still receive enhanced FMAP for that population. It's an important distinction. Medicaid flows not simply through a process where when you want something to be covered, it just happens. It is part of a pretty organic process that we go through on a yearly basis and is primarily driven by the state budget. We have a contract, so to speak, with CMS. And there's two ways in which we get authority to run our Medicaid program. That is one through our state plan, and the other is through our waiver. Our state lawmakers, the Medicaid agency, and then CMS. It's really a partnership to provide comprehensive care. From a timeline perspective, as new initiatives come on board, at a minimum, it takes approximately a year to implement something new, to receive authority, first at the state level, then at the federal level, and then implementation. I would say if you have new ideas, talk to me at least 2 years in advance and plan for at least 18 months of implementation time. And that's fast. Quickly on the numbers, overall Medicaid expenditures total $3.8 billion, with nearly $3.2 billion in spending on the benefits for members. The effective federal Medicaid assistance percentage, or as we refer to it, FMAP, that's the portion that the federal government pays, is approximately 65% across the Medicaid program, with the remaining 35% paid with state dollars. Our expenditures cross the various agencies under EOHHS. $2.8 billion is in the executive office, $301 million at BHDDH, $59 million at DCYF, and then there is some funding in OHA, DHS, and our HIV programs. Not small dollars. Our population, as I mentioned, there's about 325,000 individuals currently on Medicaid. Children and families make up the most enrollment on Medicaid, but the spending is by our disabled population. So adults, disabled adults, spend the most. Our enrollment is on the next slide. As you can see, these numbers are as of April 2024. We'll probably see a small decrease in May due to that unwinding I spoke of earlier. Our managed care enrollment, close to 90% of our Medicaid enrollees are in managed care. As you can see, the Right Care and Rhode Health Partners programs started back in 1990. Well, Right Care started in 1994, and over the course of several years, we implemented more populations into Medicaid managed care. There's several different categories, eligibility categories. As you know, we cover children and families, adults with disabilities, elders, children with special health care needs, and adults who are low income without children. What we cover, Rhode Island Medicaid benefits are pretty comprehensive. It is comprehensive insurance. You can see the mandatory benefits. So in order to run a Medicaid program, the federal government tells you you have to cover certain things. On the left side of the slide, you can see some of the mandatory coverage: primary care, physician services, lab and x-ray, inpatient hospitalization, et cetera. The optional benefits that Rhode Island covers in their Medicaid program: prescription drugs, case management and home stabilization, assisted living, dental services, optometry. It's interesting to me that prescription drugs are an optional benefit, given how we care for patients. What is not covered by Medicaid: abortion services that are not at the federal level. Abortion is not covered. We in Rhode Island do cover abortion. We do that with general revenue. Some other items that are not covered. How we deliver our care: we have two to three delivery systems, depending on how you define delivery system. We do have a Medicaid fee-for-service delivery system. That is the 10% that we were talking about, primarily made up of our duals, Medicare and Medicaid members. In individuals who have another form of insurance. And then primarily our care is delivered through our managed care organizations. That it covers our children and families, our disabled adults, our expansion members. We have a child's dental program. And then our other managed care programs. We do have a managed care program for duals. We have a PACE program here. And then we have some coordinating special needs plans for our dual population. That is a pretty quick and dirty snapshot of the Medicaid program right now. I thank you so much for your time, and we'll look forward to working with all of you.
Thank you very much, Director Souza. And I know we're trying to expedite. Thank you for being patient and awaiting. We have a couple of more presenters, and right now we thought we'd do a very brief overview from the Delta Dental perspective. And so President and CEO Joe Perrone, if I could have a few moments of your attention, and then followed by our Attorney General. Thank you.
Hopefully I get this right. Can you hear me? Okay. First of all, like others, I want to thank Speaker Shekarchi, Senate President Ruggiero, and Senator Whitehouse for bringing us all together today to discuss these important issues. They're complex. I want to also applaud them for spending the time to understand them, make sure that every stakeholder is considered when we make decisions down the line. So these are stakeholders, the provider community, the payers, the consumers, employers. Everybody needs to be considered as we look at these complex issues. And before I'm going to go quick, but before I start, I also want to applaud Dr. Kang. A few months back, maybe 4 or 5 months ago, he had an op-ed about the bill that he discussed, expanding oral surgery services to the surgical centers. And I read the article, so I had some of my team members meet with him. I wanted to understand what this meant. And it's really primarily a Medicaid issue for the Medicaid populations, and it will go a long way to helping issues here in Rhode Island when you consider that after the last presentation that 30+% of the state is on Medicaid. So we decided after meeting with Dr. Kang, and I was briefed by my folks, to support that bill. And I just want to take a minute to applaud you for that. So quickly, is there a, here we go. All right. No presentation, I guess.
It's on the bottom.
Oh, it's on the bottom. Okay. So I can't see the page. There we go. Okay. So I'm going to go just give a brief dental benefit overview. I'm going to focus then on Rhode Island's oral health care system, then take a little bit of time to discuss where Delta Dental fits into that landscape, and then I'll finish by talking about efforts going on in the state for workforce development that are very encouraging. I'm not going to spend a lot of time here, but dental benefits are still one of the most highly sought after benefits from an employee standpoint. That employees or potential employees of companies are looking that their future employer or potential employer has a dental benefit coverage. From a dental benefits overview standpoint, we looked at the American Dental Association's report from November 2023, which was updated in March 2024. And it talked about that an estimated 43% of the U.S. population visited dentists in 2021. That's appalling. That really is appalling. Among adults, though, 61% have some form of dental insurance. So that was pretty good information to learn. And then compared to other types of health coverage, really the biggest barriers to care end up becoming on the dental side of the equation. But the good news for dentally insured is that they're much more likely to go in for a dental visit than those that are uninsured. So those with private dental benefits, you can see at the bottom of the screen, have the lowest levels of cost of benefits to care, and that's where insurance plays its role. I wanted to look at the American Dental Association statistics and compare it to the National Association of Dental Plans. And the statistics were very, very similar. The National Association of Dental Plans had 65% of the nation covered with some form of dental insurance. And they also said that that was a 5-year high. So dental insurance is growing, and that's the experience here in Rhode Island too. More and more small groups are offering dental insurance that have never offered it before because of the demand from the employees. So looking at it from a National Association of Dental Plans perspective, nationally, they report that 88% of the population is enrolled in some form of dental benefits, and you'll see why that's important later in my comments. That's the combination of the dentally insured and the government programs or the Medicaid programs. And there's a record 293 million Americans with dental coverage as of their 2023 benefits reporting, with the public-funded programs becoming the most fastest growing out of all the enrollment buckets. So from a Rhode Island oral health care landscape, we have a pretty good story to tell. Right now, Rhode Island, the population is roughly 1.1 million, down a little bit from 2020, where we were a little higher. We were about 2,500 residents higher than that. You can see on this chart, the blue portion of the chart is the dental insurance covered. Then you have 13% of the population under the Right Smiles, the Children's Medicaid program in Rhode Island, which is now up to about 140,000 children in the state of Rhode Island covered under that government program. Another 14% under the Medicaid program, 9% with Medicare, and then the rest would be uncovered. So what does that mean in comparison to the national average? It means that Rhode Island is well above the national average at 92% of the folks, the residents in Rhode Island, with some form of dental coverage. So that's great news. It's a good story to tell. Rhode Island is also ranked number 6 in the country for adult dental visits as of last year, the 2023 reporting on that. So we're at the top echelon in the country for number of adults going in to have a dental visit. That's a function of so many people having coverage and having really rich benefits, to be honest. That gets me to this last point, that we did an analysis recently. Folks probably aren't really aware that we have Delta Dental of Rhode Island, but we have a subsidiary in Massachusetts called Altus Dental. And Altus Dental has roughly 100 or a third of the state of Massachusetts municipal clients. So we have City of Fall River, City of Taunton, clients like that. We did an analysis to compare the levels of coverage between the municipalities we have in Mass, which is, again, a great sample size with it being a third of the municipals in Mass, in comparison to the Rhode Island municipal benefits, including the state of Rhode Island account. And the benefits in Rhode Island are significantly richer than they are in Massachusetts. That's part of this equation that needs to be looked at and discussed as studies are being undertaken to look at the health of the landscape here. So that's important news. This next page, and I know it's an eye test, nobody's going to be able to see that, but those are the actual names from a 10-year time period of the dentists that were credentialed by Delta Dental of Rhode Island. There's 452 names there over a 10-year period. The vast majority of those are new dentists in this marketplace. A very small percentage are dentists that may have retired, decided to come back in, and maybe working at a federally qualified health center or over at Samuels, Sinclair, places like that. But the vast majority of these are new dentists to this marketplace. And when you look at that 452 dentists, they hail from 65 different dental schools. The average age of those dentists is 37. 72% of those dentists are under age 40. And from a school standpoint, Tufts graduates represented 93 of those 452. Boston University represented 119 of those 452, and then UConn represented 13 of those 452. That's not bad for a state that does not have a dental school. So these graduates are coming to Rhode Island. And I wanted to take a harder look at that, so I had our data team look at how many of those dentists that were credentialed over the last 10 years were still practicing, actively practicing in Rhode Island, and almost 60% of them are still actively practicing here. I saw Dr. Schweichenbaum earlier, and this next exhibit is actually just 2023. So last year, 54 dentists were credentialed, and to validate what I was saying, that some of these dentists are ones that maybe came out of retirement or decided to get re-credentialed so that they could practice in the state. Dr. Schweitzenbaum, the state's dental director, is on this list because he did get re-credentialed last year, or credentialed, so that he could practice at Providence Community Health Centers. So you know, great news for Providence Community Health Center. Similar stats here, you know, hailing from different schools. The average age is 35, so it continues to get younger. And 26 different dental schools were represented in last year's credentialed group. So this next page, you're not going to be able to see it either, but we decided to undertake a full comprehensive landscape report last year of the oral health the oral health care sector in Rhode Island. We didn't want to just do it by ourselves. After we finished with the data scrubs, we hired one of the top 10 public accounting and auditing firms in the country to validate the methodologies and the procedures that were undertaken to arrive at this data. So they've signed off on that at this point. And what I can tell you here is over that 10-year snapshot, in 2013, Delta Dental of Rhode Island paid 584 dentists. Last year, we paid 599 dentists. So we're paying more dentists than we were 10 years ago. The great news in that statistic is, in those numbers, there was a 43% increase in the average, in the under 40 population of dentists. So that's what we've seen with our claim payments. And as the largest payer of dental claims in the state, our data is the best resource to go to validate those types of numbers. And maybe the best news from this exhibit is that the average age of the actively practicing dentist 10 years ago was 52, and it's now, based on our claims payments, 50, and that would include both participating dentists with Delta Dental of Rhode Island and non-participating dentists. This next exhibit was something I was also very concerned about. You know, the pandemic weighed on everybody. All industries suffered as a result of the pandemic, from workforce shortages and just, you know, burnout and being overwhelmed with the onslaught of pent-up demand. So I wanted to look at the volume of procedures by specialty that Delta Dental of Rhode Island was processing for par and non-par dentists from a 2013 snapshot to a 2023 snapshot. And the results were interesting. The number of procedures that the dental community in Rhode Island was doing for our members was relatively flat, with one exception being endodontics that had a slight uptick in the amount of services they were doing for our members. But all in all, the services compared 13 to 2023 are almost, you know, they're almost identical. So our patients are receiving care, and I would assume that's the same for Blue Cross Blue Shield, Rhode Island United, and all the other dental carriers that are operating in this marketplace. This next exhibit I'm not going to spend too much time on, but there's a misconception out there that, unlike medical insurers, that dental insurers are not highly regulated. I'm not going to spend a lot of time here, but it couldn't be further from the truth. Dental insurance companies in Rhode Island, us, Blue Cross, United, anybody that is selling dental insurance coverage here is highly regulated. We report to OHIC, we report to the Department of Business Regulations, we report to the IRS and others. And listed here is just a brief snapshot of some quarterly, biannually, annually reports that we have to submit. So the information is there. If you know how to read it, it is out there to take a look at. And I'm just going to take a point here. There is a disturbing narrative out there right now about Delta Dental's loss ratios. And I would say that after reasoning through it for some period of time, I figured out what's going on, that people are looking at the 990s that get filed, and what they don't understand is that the reporting requirement for 990s is for fully insured business, fully insured dental business, and comprehensive operating expenses, so total operating expenses for the business. When you do that, you're making a misstep. You're not looking at 2/3 of our business, which I'll get to in a second. 2/3 of our business is self-insured. So groups like the state of Rhode Island and Citizens Financial Group, all the multi-state clients, the bigger groups are not represented in that number. So to weigh in on a loss ratio means that by just looking at a 990 means that you're characterizing those loss ratios. So from a Delta Dental statistical standpoint, I can tell you where we are in the marketplace. So we have 407,000 members, both in-state and out-of-state, because of groups like Citizens Financial Group and Hasbro and FM Global. So those members are represented by nearly 3,000 Delta clients. I mentioned some of the larger ones that are listed right there in the state of Rhode Island: Citizens, Lifespan, who's a good partner of ours, by the way, and Rhode Island Interlocal Trust, but there's many, many more. Our client financial arrangements, as I mentioned, break down as follows. 34% of our groups are on fully insured financial arrangements, with the balance, that 66% being under self-insured arrangements. Our client cost obligations, this is last year, over the last 10 years, we've paid $119 million on our clients' behalf. These are courtesy billings of our clients' obligations in state premium tax. So we bill that as part of our premium, and then we remit it back to the state. So we paid $19 million over the last 10 years in premium tax, and we also have a courtesy billing for our clients' broker arrangements. Clients use insurance brokers. They've become really the method for obtaining dental coverage, medical coverage, anything else at this point. 10, 15 years ago, it wasn't necessarily the case. Carriers had direct relationships with their clients. That's not the case anymore. Clients lean more and more on their insurance brokers to negotiate their insurance fees, whether it's medical, dental, or otherwise. And that's where we find ourselves. So over the last 10 years, as a courtesy billing, as part of our premium, we have reimbursed $24 million of our clients' obligations in broker commissions. So just moving down, my exhibit up here is very small, so it's an eye test for me. But our programs also include value-based care reimbursements. So in addition to dental provider reimbursements, for the last 10 years, we've had a value-based care program as part of our dental program. And those reimbursements over the last 10 years to Rhode Island dentists have represented more than $50 million. So that's a substantial part of the billing as well. And then the net premium per month. So there's a lot of dollars, millions and millions of dollars I'm throwing out there, but we keep it cost effective. It's always important for us to balance access and affordability. And the net premium per month per member for Delta Dental of Rhode Island is now at $31. So really cost effective. The statistical snapshot also talks about 407,000 members. 267,000 of those are Delta Dental Rhode Island members that are residents of Rhode Island. Another 138,000 of those are our sister plans that have Rhode Island resident members. So that's like Electric Boat, Fidelity, Raytheon, those types of employers have Delta Dental coverage, but it's not Delta Dental of Rhode Island's clients. And then, the balance of that in the population leaves about 690,000 that don't have Delta Dental coverage. And we also have 140,000 members that are in our out-of-state clients. So Citizens Financial Group, Hasbro, FM Global, those groups, Torrey Plastics, they have enrollment out of state. Torrey, for instance, is a new client to Delta Rhode Island, and they have a huge plant out in Washington State. So those members are part of us, and we pay claims to those dentists in Washington. This next exhibit, there's two charts here. One talks about how Delta Dental of Rhode Island's members are recording dental visits at a pace much well above national averages. So Delta Dental of Rhode Island members go into the dentist at a 74% clip annually versus 43% across the rest of the country. And then Delta Dental of Rhode Island's members under age 18 is even more impressive. So our under age 18 membership, 80% of that membership is going into the dentist on an annual basis. And the easiest way to compare that is to the Right Smiles program in Rhode Island, where only 43% of those children are going in on an annual basis, the state's Medicaid program, to the dentist. So just moving along pretty quickly. So what else are we doing besides paying claims and besides, selling new groups? We also spend a lot of time, as is our mission, to increase access and affordability of care to all Rhode Islanders. And beyond those that may be lucky enough to have Delta Dental coverage or Blue Cross coverage, this is any Rhode Islander. And we bucket that in 3 distinct categories where we apply our philanthropic support. 29% of it goes to general community support, 34% of it goes to access to care grants, and then another 37% goes into education, workforce, and development funding. You won't be able to see this, but this is a list of some of the beneficiaries of our support. That would include places like Samuel Sinclair Dental Center at Lifespan. They see children with a lot of behavioral health issues, and they've been a great partner for us for decades. And I'm going to talk about an expansion of that partnership as I conclude. Others in here would include Rhode Island Mission of Mercy that the dentists actually alluded to earlier. We've been the presenting sponsor for that 2-day dental clinic, free dental clinic for a long time at this point. All the federally qualified health centers in Rhode Island, they ask us for support. We build out operatories. They see primarily the Medicaid population in Rhode Island, and without our support, they wouldn't be able to provide as much care as they do. Just one example would be Thundermist last year, where I think we put in 9 new operatories, and we had a request also last year by Providence Community Health Center to put in 9 additional operatories. So that comes to us very, very frequently, and we're glad to support that expansion. Just as I finish up, some of the things that we're very excited about are the CCRI program. We started a couple of years ago a program to increase the dental workforce from a dental hygienist perspective. So we re-outfitted the dental hygiene school with new operatories, new training stations, and we put 10 dental hygienist scholarships in place up there. And that's proving to be successful. They've doubled their class size, from my understanding, and so that's something that's been good for Rhode Island. If you have a scholarship, if you receive a scholarship from Delta Dental, you have to stay in Rhode Island for a set period of time to practice with some of the dental offices here. So that's a good program, and that program's starting to get national attention. It's becoming a model for dental hygiene, which is a crisis across the country. This is becoming a model that many other states are reaching out to us, and even chambers of commerce from across the country want to understand that program a little bit better. And then I mentioned the Samuel Sinclair. So last year we entered into an arrangement with Samuel Sinclair to start the state's first oral surgery residency program. There's no dental school here, so it's hard to attract, certain specialties, and to keep dentists here sometimes. In this case, this oral surgery residency program will bring oral surgery residents into Samuel Sinclair. They'll work here for an extended period of time. They'll get to know the landscape, and the hope is that some of them, many of them, may stay here once they realize what a great quality of life it is. So that we're excited about that program as well. And then just finishing up, so what's down the line? So we're probably going to expand the hygiene program, the scholarship program at CCRI. We're also in discussions with the Rhode Island Department of Education for bringing a dental assistant program into some of the high schools, and there's other things that you can see there. So we're excited about that. It's a complicated landscape. It's one that needs more attention. It's something that if anybody would like to reach out and discuss with us, we'd be glad to do that. And we'll move forward, and hopefully people have a better understanding about what this landscape truly looks like. Thank you for your time.
Thank you very much, Joe. And now at this time, we'd like to have our Attorney General, Peter Nerona, present his comments on the landscape and our system in crisis. Thank you.
All right. If I can get this, I guess there's been some sharing issues. Like this, maybe? All right. Can you hear me in the back? Can. Good, Mike. My old friend. Dr. Wagner, good to see you, that you stuck around. Thank you to everybody who hung in here long enough to hear my comments about the healthcare system. The first question you should reasonably be asking me is, why does your Attorney General claim to know anything about healthcare? And I have to say, I was a prosecutor for most of my legal life. And it's not by choice that I have spent time here over the last 5 or 6 years. I've only spent time here because the work has been, if you will, imposed upon us. I have 6 lawyers doing healthcare today. When I started, I had one doing it full-time and one doing it part-time. The work is there for us to do. Whenever I see people in medicine give a presentation, they often give disclaimers, right, Dr. Wagner? So I'm going to give you my disclaimers. I'm married to a primary care physician, and I am the proud father of a newly minted doctor who's about to do his residency in Chicago. And so perhaps, just perhaps, that impacts my lens, but I don't think so. I don't think so. Let me begin by saying this, where we started this morning. I don't know a lot about the AHEAD program that Senator Whitehouse talked about. I did some reading that my team provided to me last night. But I know this, that the application is due in August. Right? I see some nods around the room. The application is due in August. And I'd like to see a show of hands. I won't ask you because that puts you on the spot. Who thinks we're going to have that application done by August? Do we even know who in this room is charged with preparing the application? We should know. I know. But I would guarantee that many don't, and many in the broader population don't. So let's put the AHEAD program over there until we can get our act together here to get our application in place. That's an 8-year program for 8 states that if we don't get our application in now, doesn't happen. So either we got to pick up our game now or that ship has sailed. Okay? But make no mistake, we need change. Why do I say this? Do you know that right now we are in Superior Court in a closed hearing fighting to keep Roger Williams and Fatima open? The courtroom is sealed. Now, I hear a lot in this job about transparency, about the need for transparency. Senator DePalma is a champion for transparency. Thank you, Senator. But where is the outcry from the media, if they're here, about why that courtroom is sealed? I take no issue with Judge Stern sealing it, but where is the media who criticizes my office repeatedly for not being transparent when there is nothing more important than what's going on in that courtroom? Because in that courtroom is the future of Roger Williams and Fatima hospitals. Make no mistake, they're $24 million behind in their payments. Why? They don't care about those hospitals. If they could, they would close them. Had we not forced them to put $80 million in escrow 4 years ago, they'd be closed today. They're closing hospitals all over this country. And the only difference is we have money in escrow to prevent them from doing it. That is the definition of a crisis, folks. One of my 6 lawyers is a bankruptcy lawyer. Do you think that's a coincidence? I hired him this year, Rick Gemma. I hired a bankruptcy lawyer because I see insolvency events on our horizon. And they can't wait, frankly, for a report in December. By the way, if that report in December recommends doing the AHEAD program, well, the ship sailed before the report's done. So that report's not going to be all that helpful to the extent it recommends the AHEAD program. Why are Roger Williams and Fatima in crisis? It's not just because they have a lousy owner, and they do. It's because structurally in this state, we don't bring enough revenue into the system to allow hospitals like that to function and be in the black and invest back into the healthcare systems. I jumped up when President Fernandez said he's operating a public hospital because I wanted to bring attention to the point that in any other state, his hospital, and probably every hospital in this state, would be supported by public funds. And what is the appetite for public funds for these hospitals? Zero. You know, I looked at my iPhone before I got up here. My iPhone is an iPhone 12. I don't think that's the most current model. It costs $800. And yet everybody has an iPhone or an Android device. Why? Because we think having our means of communication at our fingertips is incredibly important, and we'll pay any price to get it, right? They raise that iPhone price to $900, $1,200, $1,400. We're going to pay it because we want our iPhone. We want a healthcare system. We want bright, shiny new hospitals. We want to get a doctor tomorrow if we don't feel well. If we need a neurologist, and by the way, the one that works at South County Hospital, right, Aaron? Peter Bellafiore, my neurologist, he's great. He's this close to retirement. Does he have a replacement? No. Need a neurologist? My father couldn't get out of bed. See a neurologist. See you in 6 months. Who said it? Dr. Wagner said, I think it was you, doctor, who said, if you don't know anybody, you're not getting an appointment. That's true, because I'm married to a primary care doctor. Let me tell you something about primary care doctors. Somebody told me once, cry me a river for healthcare providers. Well, I'm married to one. She's a trooper. She could have been a Marine. She's never complained in the 30 years that I've been married to her, and I knew her before. Obviously, I got married. I met her when she was a resident. Has never once complained. And I've never seen anybody work harder. And I like to think I'm in an office and have held offices where people like my team work pretty darn hard, but nobody works harder than my wife. She is on that computer every night of the week to 10 o'clock. She's on it Saturday morning. I know Senator Ujafisa, your husband knows. Mark, he's a primary care doctor. If we value those gatekeepers to our health system, we value them so much that you can't see any other doctor until you go through them, right? The idea is that they're going to manage your care. And yet we pay them the least, our primary care providers. We pay them the least to manage all of those referrals. And I will tell you, as somebody who has turned 60, I need a hell of a lot of referrals, folks. More than I'd like. Why can't Roger Williams and Fatima hospitals make it? It's because they are a 70-30 Medicare and Medicaid payer versus 30% commercial. Now, Martha's absolutely right. That commercial is the train that is trying to pull Rhode Island into the 21st century when it comes to our medical system. You and the other commercial payers, because you're not the only one, but we know you're the big player. I remember going on Newsmakers, and Ted Nesi and Tim White asked me, well, how do we get more revenue into the system? I said, grow the economy, and they scoffed at me. They scoffed at me. Ha! Make no mistake, getting people out of Medicaid and onto commercial insurance is the vehicle by which we can begin to solve this problem in part. But do we ever talk about the economy in the context of urgency and what it means for healthcare? Not until today. Not until today. Critical. So we've got a lot of people on Medicaid and Medicare. We're old and we are economically challenged. And when I say old, I mean me. So no one's offended. And then our rates are lower than our neighboring states. So we've got the double whammy going on. And we need to fix that problem. We need to grow our economy, and we need to increase our rates, folks. Now, the AHEAD program may well be a means to increase our Medicare rates, but if we can't get our application in time and the ship sails for some period of years, how are we going to do that? What is our plan to leverage our Medicaid dollars. These are all things we can do if we recognize the scope of the problem. And if you're not in the game with respect, you don't see the scope of the problem. Okay? And, you know, somebody said to me, Kate, can I have my water, please? Somebody said to me, well, you know, maybe it wouldn't be the worst thing if Roger Williams and Fatima closed. And this is somebody who is involved in government at a high level. And Kathy, Greg, wherever you are, don't ask me because I'm not going to tell you who it is. But we know, right, Lynn Blaze? Where is she? We know that we can't close those hospitals. It's not just about the jobs. I know you guys care about your jobs, you and George and Pat, if he's still here, Pat Crowley. It's not just about the jobs. It's about the patients first. And John Fernandez and Mike Wagner have both told me they can't take the overflow. So we have to fight and save those hospitals. And how do we fight and save them? We get those Medicaid rates up. We get those Medicare rates up if we can. The delegation needs to fight for that, and I know that they will. We need to leverage our Medicaid dollars to every last dollar, as Martha points out. And if we're not doing it, we need to know why. Because I am telling you, if we don't, people talk about Steward, like, look what's going on over there. Prospect, Roger Williams and Fatima was going on 3 years ago. It's why the $80 million is in escrow, because if it wasn't, they'd be closed and the day of reckoning would already be here. But we can't wait till the end of the year. I spoke to some emergency room doctors not long ago. And we were talking about private equity in healthcare. And of course, that has driven this crisis when it comes to Roger Williams and Fatima. It's driven the crisis, no question about it. But I said to them, it's going to take spectacular failure for people to wake up. And I would argue, Doctor, that given the state of oral health with children, we are in a state of spectacular failure. We wonder why Providence school children don't perform the way we'd like. Well, if you can't eat and you can't think clearly because your teeth hurt, is it any wonder? Is it any wonder? So we need to fix those three components of our healthcare system, and we need to do it now. Because if we don't, we are going to have a more spectacular failure that not just the Brown ER doctors will recognize, and not just what you recognize. We are too fractured in our thinking, we are too siloed in our thinking, and we don't sit around the table and talk to one another enough directly and honestly. Even though that's a hard conversation, and Martha, we've had hard conversations, haven't we? I urged you to be bold, and you looked at me like I was nuts. God bless you. You know what I said to Martha? I said, don't spend more money on health care when it comes to providers. Just reallocate it. Make Rhode Island a magnet for primary care doctors, right? Take a little from the specialists. Sorry, specialists. Give some more to the primary care providers. Rebalance how we pay. I don't know whether we can do that or not. Martha would probably tell me 10 reasons we can't. But it's that kind of thinking that I believe can move us forward. But what I know won't work is continuing to do what we are doing today. So what can we do? Well, for one thing, the governor's group that is talking about planning on health care can invite my office to participate. That's number one. Because I would argue no one has done more in this state in the last 3 years in defense of health care than my office. And that's a tribute to the team. That's a tribute to the team. When we're at the table, we advance the ball. And I'll tell you what the best evidence of that is, that I can name every one of you out there that does healthcare by name. You know me and I know you because you spend time in my conference room. And even though we don't always agree, right, Martha, we talk. And it's through those conversations and moving the levers of government that we can move this ship forward. But we can't wait, and we got to have urgency. George Nee told me to bring some urgency, George. How am I doing? I'm going to leave you with one thing. The beginnings of the correction are reworking our state regulatory bodies. With respect, we've got OHIC. Corey, you and I need to get together. Love your work. We've got OHIC in one corner doing great work, but it's over there. We've got the Medicaid office doing great work, but they're over there. And frankly, you need to be empowered and you need to be grown. I don't know how many more people Massachusetts has than you, but I'd give you more, right? You're trying to move this ship and you don't have enough people, and you need a champion to get those people, because there's nobody more important than the Medicaid office in leveraging our federal dollars. So if you take the Medicaid office and you put it with OHIC, I know you want to be independent, and we'll figure that out. This is just my plan. It's never going to happen. This is my plan. And then take the Department of Health and bring them to the table as a true regulator. True regulator. Again, empowered and funded and built to do real healthcare policy. So we're not always relying on the Rhode Island Foundation. God bless him. David did his classic In and Out. I love him. But we're not always relying on the Rhode Island Foundation to give us the data. The state ought to have that data. I asked Martha, well, tell me about Massachusetts. She says, I can't. I got antitrust problems. How can we analyze these issues if we don't have the data? Let's figure out how to get the data. Let's get in the room and figure this out. You know, the merger wasn't good for Rhode Island. It wasn't good for Rhode Island. It was putting two weak places together, which never would have worked, particularly with leadership that didn't have a vision as to how it would actually work. But we are now in a place where we have great leadership in this state, and Dr. Wagner, and President Fernandez, and Aaron, and others. We have a great labor perspective from Lynn and others that can inform the policy decisions we need to make right now to get this done. And you know, there are moments in our history that require urgency and direct speaking and not being afraid to rock the boat. And maybe when they put an 8-inch hole in my back, they took out that part that maybe hold back a little bit. But as a state, we can't afford to hold back, right? We are on the precipice of a disaster, and the beginnings are there. You know, the Roger Williams Fathom is there. You can't find a doctor's there. The children can't get their teeth treated. We can fix it, but we need a state of urgency. We need to understand what's real, and we need to get in a room. Not a room where we talk at each other like I'm doing to you, frankly, but where we talk together. And you tell me, Peter, you just floated 15 things, and 2 of them make sense, and 13 of them make no sense at all. And I'll say, great. Tell me how we get those kids treated. Do dentists need to take more Medicaid patients? I don't know, doctor, but maybe we need to talk about that. Martha, do you need to raise your rates even a little more? Maybe that's true. What can we do, my friends who know more about economic policy than I do, to move our economy forward? You know, I love small businesses, I do. But we need to bring some big businesses in here too. We can do it. There's no better place to live. I've dragged my wife here from New Jersey. Actually, she took over Dr. Wagner's panel at what was then New England Medical Center 30 years ago, because she loved this state, and she'll never leave it, and I know we as Rhode Islanders never will either. So let's fix this. We can do it. Thank you very much.
Thank you very much, General. At this time, before we have closing remarks from the Senate, are there a few questions? Because I know we spent a lot of time hearing from our presenters. And while we still have the General here, are there any questions that anyone would like to ask? Don't be shy.
Knows I'm not.
Questions?
Certainly, Aaron, I think. Okay,
All right, thanks, folks.
Aaron. And Helena, okay. Aaron, you'll be next. Helena from the health centers.
Thank you very much for those comments. I don't so much have a question, just want to expand this discussion. I represent the 8 federally qualified health centers in the state, and their model of primary care is a little bit different, and I think would add a dimension to our conversation. 2 ways they're different. One is they incorporate the patient voice and the community voice in everything they do. It's part of their governance model. And I think we need to think about governance of the hospitals. We need to think about the governance of all of our healthcare facilities and how we incorporate that patient voice. And the second way that they're different is they do deliberate coordination across primary medical, dental, and behavioral health. And it's a model that we all could learn from. So
That's
thank
great,
you very
thank you.
much.
You know, and you remind me that Blackstone Valley Community Health last year didn't have a primary care provider, if I remember correctly. And I want to thank Dr. Wagner. I think he may have stepped out, but it was Dr. Wagner, after we had a conversation, reached out, and I believe that issue's been remedied. So I'm grateful for that. Thanks, Elena. Aaron? As far as I'm concerned, you certainly can.
I'm a Senate and Chief Justice Judge, and I'm a Commissioner in Tri-State. I act at home because I'm disabled. I called your office in the past about the police department before all this became out of control. And I seen it coming, and I know the 2 parties that made it happen more so quicker than it might have been. And what I'm talking about is attacks on children, attacks on disabled people, attacks on people that are less fortunate. They can't get out of the house.
So can I suggest that one of my crack team who's here, Keith Hoffman, will come up and talk to you about that. And I'd love to hear more in a smaller setting. Thank you.
Talking about the thing that you spoke about.
Thank you very much.
Moving along. And I also called your office about the police department, and I had an issue. Kayla was at your office. She's now at the governor's office. And I have put in 35 acts. I am helping reform the police department, the doctrine, the pharmacy, and certain things. And when I did call your office, you said you would handle a claim for me, 3 of them. And you kept on asking me, you got the money, you got the money. That is not what Attorney General's office does.
Okay.
You all said that you would, when I said no, you said that you would just talk to the police department. That is not delegating, that is not making change, that is not helping anything. So, to my understanding, the Attorney General is to follow the police department. Am I correct?
Well, ma'am, I can't
Yes or no, sir? I'm trying to quickly do this.
I can't answer that question, and I think with respect, I think we're going to go back to healthcare, but Keith's on his way up to try to understand your complaints a little bit better, and we'll do anything we can to try to make it right. So thank you.
I tried to get to your office.
Nice to see you. Thank you. If I think there's a question down here. So we're gonna take Aaron's question if that's okay, but Keith's on his way. Sure.
If the doctors treat the patients with more respect and not give them more appointments and not do surgeries and just make money by doing surgery, by doing appointments instead of doing the actual act of surgery, then maybe the people will come to the doctors and they'll make more money. And I have another act that I'm going to write to the Senate, and some of these doctors, and if some of these doctors don't get paid as much and get paid for what they're doing, then maybe there'll be more incentive for the doctors to do better. Thank you.
Thank you very much, ma'am. Appreciate your input. Aaron, go ahead, my friend from South County. I want to point out I was born in South County Hospital.
Thank you.
And my children as well.
Proud of that fact. And thank you
Mr. Attorney General, for your advocacy. You were raising the alarms. You've been doing it consistently for a long period of time, and we greatly appreciate that.
Thanks.
I just want to say, as the CEO of the last independent health system in the state, one of the first questions I got asked when I came into the role over 5 years ago was, when are you going to merge with somebody else? And we've talked to a lot of people. We've talked to a lot of health systems in other states, and I've heard a lot of concerns about out-of-state institutions coming into Rhode Island. Let me tell you something. Don't worry. Nobody wants to come into Rhode Island. Don't worry.
I hope that's not because of me, Aaron.
No, it's not because of you. I talked to a prominent out-of-state, one in Mass or Connecticut. You can probably guess which one. Well-respected, nationally recognized health system. They said, Aaron, we love your health system. We love the quality you provide. We love the patient focus you provide. But I'm going to tell you, Rhode Island is one scary place. Worst state to practice for doctors. Any list you look at, highest malpractice, you heard from Dr. Wagner earlier, no limits, carried interest from the time of filed claim, regulatory environment, depressed rates. We work next to Yale New Haven Health, who loves to leverage their 20 to 30% higher commercial rates and steal our staff every single day. They steal our doctors, they steal our nurses, they steal our allied health providers. It is not just a doctor issue, it's not just a nurse practitioner issue. This is a system issue. This is a macroeconomic healthcare issue. And Martha conveniently forgot to mention that Blue Cross underfunds commercial in this state, as well as Medicaid and Medicare. Parity is our true north if we want equality, if we want a level playing field in healthcare in Rhode Island. We do have to invest in it. We are going to have to pay for it. And they're going to bring draconian numbers up, $500 million. It's actually $167 million, the two bills that are in front of the House and the Senate for the first year. And no, it's not going to solve every problem, but it's a start. Ahead would be great. If you get parity across Medicare, Medicaid, and commercial in one fell swoop, sign me up. But I agree with you, Mr. Attorney General. I don't think that we're going to be able to get our act together in time. And why not start getting there instead of kicking the can down the road over and over and over again? Definition of insanity is doing the same thing and getting different results. Why don't we do something differently? Why don't we start somewhere? Commercial, our bill would create a modest investment at the state level, 20, 30, 40 million, for $176 million of infused benefit to the health system. And yes, it would cost some money, but it would cost what it costs everywhere else, just like gas. We have to start somewhere. The crisis is now. It's not 2 years from now. It's not 3 years from now. You heard Medicaid. If we fix Medicaid, that's 18 months later, right? The crisis is now. And so I just want to encourage folks just to understand that you can't find a doctor, you can't find a specialist, your hospitals are crumbling. We've had 5 out of 10 bankruptcies in the state and 2 more possibly to come because we are underfunded in every leg of the healthcare delivery system. We have to face that fact, or we have to choose to have a 2-tiered health system in New England, Rhode Island, and everyone else. So that's not really a question. That's my comment. And I just want to say thank you for the urgency. I urge the House and the Senate to do something this session. Something. Let's compromise. Let's get people in a room and have a conversation about what can work. Not just what we don't want or what we don't like, what could work this session to start filling that gap before it's too late.
Well, I agree, Aaron. I think everybody has to be willing to leave something on the table. And I think that if we don't do that, we're in real trouble.
Wholly agree.
Any other questions? Yes, hello.
Hey, Wayona Nelson Davies from the Economic Progress Institute. And I have a comment and a question, sort of like a let's dream question. And one thing I would like to say, and some people have hinted to that, is sort of centering patients' experience when we have these conversations, sort of looking at, what are the positive health outcomes we want at the end of the day. And so in addition to doing healthcare policy at EPI, I spent 10 years as a legal aid attorney actually working with providers on their healthcare team representing the patients with social determinants of health issues. So always thinking about, at the end of the day, what are we doing to increase patients' outcome? So I'm curious, and this is just a question just to throw it out there, and I know we're thinking of the problems of the day. So I'm a little bit curious, and maybe a little bit more than curious. What are your thoughts about universal health care?
Yeah.
Opportunities and concerns.
Yeah, look, I think universal health care is something worth talking about, but we're nowhere near talking about that. What I worry about is that we're doing healthcare piecemeal without a strategy. We rely too much on reports. We wait for reports. They come out. They make recommendations, as Corey's did. Do we follow through on those recommendations? Where do they go? One thing I neglected to say, as we talk about equity in healthcare, is it's always the poorest and communities of color that will suffer first. If our community safety net hospitals go, sure, if you're white and wealthy, you'll get your health care. You may get it out of state. But there's a reason why Roger Williams and Fatima have that percentage of Medicaid patients, because they're treating communities of color and they're treating poor. Everybody's doing it. John's doing it too, obviously, but it's a higher percentage there. And those safety net hospitals, we simply can't do without. They're really strong hospitals. I mean, I know the workforce. It's incredible. I mean, nurses are the backbone of our system. There's no question about it. The workforce, nurses, other advanced professionals, other folks who work in the hospital are the backbone of the system. They're doing great work. We need to figure out how to save them. We're going to do everything we can to save them. I'm really worried about an insolvency event, and it's only by proving, frankly, that the state can figure out how to do health care that we may be able to convince a bankruptcy judge somewhere to keep these hospitals open. And make no mistake, folks, that bankruptcy court isn't going to be here. Okay? It's going to be the place of Prospect's choosing if they go that route. Stewart and Prospect are two sides of the same coin. Prospect actually started first. Private equity steals the money, the hospitals go under. That's the plan, and it's deliberate. Thank you.
Thank you.
All right. Jesse, how are you doing?
I'm great. Jesse Martin, 1199. Thank you, Attorney General, for your comments, your critical thinking on health care. Thank you to the Speaker and Senate President and Senator Whitehouse for this forum. Your passion about Medicaid connects with our membership at 1199. We represent healthcare workers from federally qualified clinics to women and infants to group homes to nursing homes, really the entire medical experience of the poor in Rhode Island, from birth to death. And when you increase Medicaid to these workplaces, it is an opportunity also for the state to make sure that the wages and benefits of working conditions of healthcare workers are improved. Because if healthcare workers are no longer on Medicaid, because they can get private insurance through their hospitals or through their nursing homes or through their group homes, that improves the entire healthcare system. And in particular, I think it's something quite phenomenal that in this session there's a lot of movement around increasing Medicaid rates. And we need to make sure that when we increase Medicaid rates, we are making sure that employers who are getting those increases are doing right by their employees. The conditions of workers in healthcare are also the conditions in which the care is being given. So we appreciate your comments and your thoughtfulness in the forum. Thank you.
Thanks, Jess. All right, I think we're good. Thanks, everyone. Thanks, Lynn. Awesome.
Thank you very much. At this time, we'd like to hear from Lita Pearson with closing remarks from the Senate.
Unfortunately, I won't be as fired up as the General, but I'm going to do my best. But General, thank you for all your work and your advocacy on this issue. On behalf of President Ruggiero and the entire Rhode Island Senate, I just want to thank you all, not only for being here today, but importantly, the time that you're dedicating, not only today, but every day throughout the year, worried about Rhode Island's healthcare system and what we need to do to improve care. This will only work if we all continue to come together. At the beginning of this session, the President and I both, in the beginning of the year interviews, had mentioned how important health care was going to be on the Senate's agenda for this year. And that was really driven by meetings with many of you. Many of you who've come in, you've met with the President, you've met with myself, you've met with many of the other senators. We hear it from our constituents all the time about how hard it is to find care or coverages that they have issues with. But even more so, the work that each of you do and have continued to do working with senators in the chamber to bring forward issues, I can tell you is the most important. And I just want to start by thanking and recognizing both Chairman Miller and Chairman DePalma, who are both here today, and their committees. Their committees have some tremendous membership who has been consistently focused on this, and they've actually all been here today. And I want to thank them, Senators Valverde, Senator Mario, Murray, Loria, Ujafusa. These are all senators who care deeply about health care, and the conversations you have with them really are what cement health care being such a priority in the Senate. So thank you for that. We know, and we've heard from many of you today, that healthcare continues to be a struggle, continues to be unaffordable in some areas, and also often the workforce challenges that you all face. And what we also know, which is really clear, is there is no one silver bullet to this problem. Every single one of us has a different issue, a different perspective, a different concern. But I think we all recognize the urgency in what we need to do to act. Not saying we covered every issue or did everything perfectly, but earlier this year, the Senate introduced a healthcare package. And the intent of that package was to continue on so many big pieces of work that we've done. And I know we've spent a lot of time today talking about the problems that are still in front of us. But I want to just take 1 minute just to think back on how far we've come in the last few years. Chairman DePalma pushed for probably a decade for rate review prior to us actually doing it. The work that we've been doing on investing more and more and more into Medicaid and making sure that we bring those rates up are critically important to the health of the entire system. We've made sure the state-directed payments to hospitals through a partnership with the Hospital Association and others, we've really made sure that we're getting and maximizing federal dollars into our state. Transforming Eleanor Slater, the implementation and launch of the CCBHCs. All of this work is critically important. And the Senate is focused on continuing those initiatives, working to address primary care. I saw Deb earlier when she spoke from the CTC. So much of the work that the Senate's put in the healthcare package this year was Deb working with Senator Loria, thinking about how do we make sure we keep more primary care providers in the state. And I mention that specifically because that is how we're going to keep doing this. We need all of you to keep working together. We need all of you to keep sharing ideas. We need all of you to keep bringing those ideas to us. We rely on your expertise. We rely on what you bring. And so our ask today for each of you is to continue talking, to keep bringing those ideas. And I think Senator Whitehouse's ask was pretty clear this morning. Rhode Island has to face the reality. We are a state that sits in between two states that have much higher incomes than us. Their insurance premiums can be set differently. Their system can afford a different cost basis. Rhode Island is a geographic, strategically discompetitive position, and we know that. The other thing, though, we know is we need to drive more revenue into our healthcare system. Not everything can be solved with money, but let's be honest, a lot of it is. And the amount of revenue we can continue to drive in from state dollars or from commercial premiums is limited. We also have to be cognizant about that. And so finding ways to drive more federal funding into Rhode Island is critically important. And Senator Whitehouse's point around leveraging the AHEAD application in the program is something that we all need to think about. And we all need to think about how can we figure out working together, how do we get into the boat, about how do we make it happen. We know that the devil's always in the details. And we know that we would need to make sure that the global budgets at the regional rates are there. We need to have strong quality measures, strong performance benchmarks. But imagine the transformation we can make in our healthcare system if we were able to achieve that rate parity with our neighboring states. This initiative and many will require all of you to work together, work to think how can we make this happen versus why can it not? But that's what we need to do. And so I'll close with this. Keep working together, keep brainstorming, keep bringing those ideas to us. There's much work ahead. We can do it. And it starts with each and every one of you here in this room today. So thank you all for being here today, and thank you so much for this great opportunity. Thanks, Lynn.
Thank you, Leader Pearson. On behalf of the speaker, we would like to thank each and every one of you for being here. This was quite a demonstration of time commitment and urgency, and we have heard a number of themes and issues that we can work on together, and I am certain that we will be following up with many of you, particularly in the final weeks of this session, but as well into the foreseeable future, because the solutions will not happen right away, but we can at least start planning, which is what we all need to agree to, that work is to be done on this issue in tandem with the providers, with the caregivers, our hospitals, nurses, our physicians, and with all of you in your various roles. We have a lot of work ahead, but the time to start is now. Thank you all again on behalf of the House and behalf of Speaker Shekarchi. We really appreciate it. Thank you. And if you all could, if you could just leave your badge right on the seat, we'd greatly appreciate it. You don't have to do anything else. Thank you very much.